Good morning, everyone. Welcome to the Empowered Caregivers Forum Session 3. I thank you so much for being here this morning. We are excited. Today, this is our last session for 2021. We have some great things that will be coming forth in 2022. Myself and Ray Blaylark is here today, and we are excited. So I'm Carla Lewis, founder of Kids Conquering Sickle Cell Disease Foundation, mother of a sickle cell warrior, now a teenager. I have to call him a young man. I know I get so hard, my heart gets so warm when I speak to him and call him a young man. I'm still getting used to. So I didn't know this transition is so much impactful for me as well as it is for him. So I think I'm going through different things, but we are here to join together. So I am going to tell you a little bit. I'm based here in Orlando, Florida. Our organization provides support services to our warrior community, as well as education to the community at large. We are, even though we're based here, we are an organization that is welcome to provide information and education on a national basis and international base. We are on social media platforms, as well as we are busy in the community. We have our Young Adult Sickle Cell Alliance, we have a trained young adults that provide presentations to the community, educational presentations, and share their experience. So I want to thank you today for joining our forum. We are here for support as well as to learn. So I thank you for joining us today. And I am going to introduce you now to Miss Ray, which we're happy to have her here all the way from Minnesota. And we are partners in crime on this forum.
Good morning, everyone. Thank you, Carla. I so appreciate that. Yes, I am Ray Blaylark. I'm the president and CEO of Sickle Cell Foundation of Minnesota. Our mission is to improve quality of life for patients, for individuals and communities impacted by sickle cell disease. Our number one goal is primarily localized in the Minnesota community, but we are, much like many of the sickle cell organizations, we have a reach well outside of Minnesota, and we support any and every community that is impacted by sickle cell disease, no matter where you're located. So we have a number of programs as well that we do a community outreach, but we also, as I said, go beyond the borders. We work with patients, caregivers, and providers in the healthcare space in order to improve the outcomes for this precious community. I am so excited to be here for our third and final session. Every session has been energizing, has been empowering, has built upon the last session. So if you haven't seen the previous two sessions, make sure that you look them up so that you too can be a part of that and you don't miss out on any relevant information. Carla, you are right on. I am the mother of a 25-year-old warrior, and I remember those days like it was yesterday, because let me tell you something, transition is not a one-time stop, and it's not a one-person experience. The entire family experiences transition. That young adult who's experiencing transition is in the middle of that. And so this is an exciting time from many different perspectives. And what we hope that we can do is that we hope that we can give you tools to put in your toolbox so that you feel better prepared in order to be the caregiver that you want to be to someone else, but also that you don't forget that you also have to caregive for yourself. Back to you, Carla.
Thank you, thank you, thank you. Today we have our first presenter, which is Dr. Naga. He is the division chief for Nemours Hematology Oncology. Dr. Naga is well-rounded in the practice and study of sickle cell disease. Dr. Naga is, I'll have him introduce himself a little bit and tell you a little bit about his bio. Dr. Naga.
Thank you, Carla. Thank you, Ray. And thanks to all that have joined today. I do appreciate the time you've given me to sort of share my thoughts. I cannot thank both of you and all similar organizations that are championing the improvement in cures for sickle cell. Providers alone, physicians alone can never do that. There's a great need, and there are a lot of gaps in our healthcare, as you all know, that impacts access to healthcare and also delivery of healthcare. So me just knowing what needs to be done and telling the patient doesn't make it happen automatically. I think organizations like you that reach out to families, that provide resources, are instrumental in making sure they get the care they need. And so we really, really appreciate you doing that and also giving us a chance to talk to the families directly, whether they are in our practice or not, but in our communities, both locally and nationally, like you said. I'm a hematologist, oncologist. I've been in practice for a little over 25 years. And I have great interest in sickle cell anemia from the time I trained in Chicago, where there's a very large population of sickle cell community there. Since coming to Orlando about 15 years ago, I've participated in at least 2 or 3 sickle cell trials at our site as a principal investigator. Our current director of sickle cell program is Dr. Dorothea Douglas. You may have met her on her previous talks to you. But together as an organization, Nemours has over 800 sickle cell patients in our practice. And so we are proud that we were just recently awarded a $10.5 million NIH grant, which is basically focused solely on addressing the stigma around sickle cell disease and how underrepresented minorities have poor access to healthcare and how to improve healthcare and outcomes for children with sickle cell anemia. So together with our team up north, I think we are poised to make great impacts on the care of sickle cell, but not without your help. So thank you again.
Thank you so much, Dr. Naga. So we are going to pretty much do our connections exercise. We want to know a little bit about who has joined us today. So if you can introduce yourself and tell us where you're from and your relation to sickle cell, that would be great.
And if you don't want to speak live, you can go ahead and put it in the chat box as well.
Yes.
Okay, well, that's all right. We'll move forward.
Well, thank you. Now we would like to take this time. We're gonna have our presenter, Dr. Naga. I don't know if you have slides that you would like to share on the silent damage of sickle cell. We know that sickle cell impacts the entire body. We are going to allow Dr. Naga to present. Thank you, Dr. Naga. Let me know if you need to share your screen. I can give you that capability.
Yes, I'd like to share some slides. And
okay, so I'm going to.
Yeah, also tell me how much time I have so I can make sure I don't hog up all the time.
Okay. You have until about 11 o'clock.
Okay. And I think I need your permission to share the screen.
Yep, I'm going to give it to you. Share the screen. Did you see it come up?
Let's see. Yes.
Okay.
Yeah. Are you able to see my screen?
Not yet.
Share. Okay. How about now?
Yes, it just came up.
Okay. All right. I will get started so we can finish on time. I'm just trying to see if I can maximize the screenshot. I think I'm not able to move it further, so I'll just start here. So I think at the very end of September, in the beginning of October, I don't want to forget that we are recognizing, and celebrating the warriors with sickle cell anemia. You may remember that this recognition was passed by Congress and signed by President Reagan in 1983. And we've been recognizing this month, for all the things we need to be aware of and care for with patients with sickle cell anemia. The outline of my talk is going to be shedding a little light on the burden of sickle cell disease as we know, how it affects life expectancy, a little bit about chronic pain and the chronic organ complications. The reason I, love talking about this is that oftentimes in treating acute complications, we lose sight of what really we are trying to prevent or control. And sometimes that is also lost in conversation if you're not able to come to clinic on a regular basis. And as children grow, transition into wonderful adolescents, young adults, it seems to have a great impact as far as how it affects them after they discharge from our practice or graduate from our practice. And so for all the children, the adolescents, the parents of young children, I want you to take important notes on really how this affects you long term, as opposed to the one episode of fever or pain crisis or an acute chest syndrome you might have. And this cannot come to light without understanding exactly how it affects everything else. So the natural history of sickle cell anemia, we all know some things and many things about sickle cell anemia, but really all that we know about the natural history comes from very few studies, very important studies. And some date back as far as back 1973, the Jamaican cohort study of sickle cell anemia, which followed 100,000 consecutive deliveries. In the United States, one of the early largest ones were the cooperative study of sickle cell disease, which I will refer to a few times, where 3,000 individuals were followed all the way until 1998 for complications of sickle cell disease. And we tracked the incidence of how frequently complications occur, both acute complications and long-term complications. After 1998, you can see there are only like few single institutions that actually have been studying their own cohort of patients. The CDC has encouraged California and Georgia for a sickle cell data collection program, which can track up to 7,000 patients. And there's a London cohort and a Dallas cohort. So much of the information I'm giving you comes from what we have learned from these studies. And everything else may be, individual or a small anecdotal cohort of patients. Let's talk a little bit about the burden on life expectancy. And here's an important, chart. I hope you can see this. This is the estimated life expectancy as of the most recent data. This I would say is, 2015 data that has been projected to 2019. This was published in the Journal of American Medical Association, a very, leading journal. This compares how long people with sickle cell disease live compared to those without sickle cell disease. I'll walk you through the graph. At the far right, you see US general population. And then on the y-axis, you see life expectancy at birth. So if somebody is born today, US general population, you can expect to live into your 70s. If you go to the leftmost part of the graph, you see the SCD cohort, sickle cell disease cohort. If somebody is born today, you can expect to, on average, live into the low 50s. That's 2 decades cut short because of the disease itself. And we have to understand that many of these limitations, many of these restrictions that have been cut short is primarily due to the long-term side effects or complications. There are some other graphs here. I'll come back to that in a bit, but I just want you to see the difference between the general population and this. Of course, we made a lot of advances. This number on the left side, right, we are now in the low 50s. Used to be 20s or 40s. Now we are in the 50s. So we have come a way, but we have to still go a long more way. These are other graphs I'd like to walk you through. These are the medical graphs that this was published in 2014 in the American Journal of Hematology. And the graph on the left basically tells you what percentage of patients are alive. If you track them from 100% at start, and then you see how, as the age goes on to 80 years, for example, here, the curve starts dropping rapidly after age 40. And you can see that the two lines, one is a dark line and the dotted line, are for the different types of sickle cell anemia. So the curve rapidly drops off, and the survival at 50% is only around age 50, as you can see. The chart on the right shows how patients do if they have some sort of organ failure. Today, we are here to talk about what happens to the organs long-term in sickle cell anemia. You could have one organ affected or more than one organ affected, and the severity of being affected by more than one organ also decreases your chance for survival. So it's not just that you have sickle cell disease that is going to affect your survival, but really what happens to your organs in the meantime and how severely are they affected, that also affects how long someone can survive. Here's another a couple of graphs with estimated life expectancy. And again, this is actually just for children from age 0 to 18 years on the left in graph A, as you can see. And you can see that there are different, on the fourth chart on the right here, which has all the different colored charts, you can see that there are different types of cohorts that were followed. You can see the Jamaican cohort, which is in the brown line, 1973 to 75, starting at 100%, by age 18, there's only like 75% of them alive. But you see the Dallas cohort, the purple line on top now, which has been following patients after 2000, that's nearly 95, 98%. What this means is that children who are born with sickle cell anemia, even in the United States or elsewhere, whether high-income country or low-income country, you did worse if you're born in the early times, and you're doing much better. Nearly all children born now are almost surviving to 18 years of age and older. So we've done a great job of controlling this disease's devastation in childhood because of immunizations and because of aggressive treatments. And then we see that even though 93, 95% are going to survive through 18, when it comes to adulthood, you're still down to only 52 years. So there's a lot that's happening that may be starting in childhood, that goes on through young adulthood, that really is what's restricting. And what do we know about it? What can we do about it? That's what we need to be very, very aware of. There's definitely light at the end of the tunnel. This is a recent publication by Dr. Ballas, and he actually reported 4 patients who lived into their 80s with sickle cell disease. Only 4 patients, a very small number, but they have been able to do that with modern age medicine. All these 4 actually were women. In fact, in all the studies that we have seen, when we look at graphs like these, the survival for women is slightly superior or better than survival for men. So it's not surprising that the 4 octogenarians were women here. But again, that's not everyone, so let's not forget the important fact there. Why does this happen? Why does this happen? This is actually a slide that I will also walk you through, which basically says, the top half says there are genetic reasons why somebody's disease can be more severe, which is in the red towards the right, or can be less severe. And then there are non-genetic reasons as to why somebody can have more severe disease or have less severe disease. The genetic modifiers you cannot control. For example, everything else being the same, children born with genes, inherited from the Bantu region, they have very severe phenotypes of sickle cell, which means severe disease. Arab Indian, families with sickle cell anemia have much less severe problems. So that genetics is something that you're born with, whether it's where you're born, your genes came from, what type of hemoglobin F level you have, et cetera, et cetera. That you cannot modify too much. And there are non-genetic modifiers. And you can see here, many things are near: smoking, living at altitude, poverty, infections, humidity, wind speed. These things can affect the frequency of the crisis and complications you get, some of which are actually amenable to control and some again are not. So what happens when some have more severe symptoms and some have less severe symptoms? So there was a recent, very recently published survey, and it's called the International Sickle Cell World Assessment Survey, or SWAY. And it actually got responses from over 2,000 patients from 16 countries and 6 geographic locations in a 6-month period. And they asked them, like, what percentage of patients feel that sickle cell is impacting their daily life. By this, I mean gardening, cooking, doing the usual things. And you can see how patients respond that they avoid intense physical activity. They worry about painful episodes while exercising. It affects their sexual activity, relationship with spouse, household daily activities. 38% think that it affects even daily activities. Again, these are adults. But the important thing is this is what sickle cell does to you, day in and day out, day in and day out. On this slide, we're seeing again, how does it affect you, not just physically, but also emotionally? So overall, 60% say it affects their emotional well-being. They feel frustrated. They're worried it's going to get worse. They will worry that they don't have anyone to take care of them. They worry about dying. They worry that they feel worse than the doctor thinks that it is. And that is very, very true. We all underestimate the pain symptoms or other symptoms that children and adults with sickle cell anemia feel. And this sometimes, even discourages patients from seeking care because they don't believe me, they don't trust me. But all these things go on to impact how you're going to seek care, how you're going to follow care, and that affects your outcome. But it's very, very disheartening to know how significant this is. More than 40% of patients, experience these things. How about the impact of sickle cell disease on careers? So again, 53% say that, oh, it has limited me to certain careers only, and we know this. Sometimes they're not able to keep a job. They need special accommodations at jobs that some employers are not, open to. This affects finding a suitable job that you like, keeping it. And then you also get, some people say they get turned down at job interviews because of sickle cell. The impact of sickle cell disease on schooling. In many ways, the society we grow up in, education level affects your career prospects and your income and everything else. Definitely sickle cell disease has reduced attendance at school for many children, if especially their condition is not managed well. It has lowered their interest in school, and some feel it has stopped them from progressing further in the education. These are all things that are patient self-reported. It's not a doctor trying to, put their thoughts into it. All the world over, right? This is 16 countries, 2,000 patients. And why is this happening? Because patients with sickle cell experience both acute complications, which are in yellow, and then the chronic complications. And some get the acute while they're also experiencing chronic complications. But what this does to your physical health, to your emotional health, how you seek and get care, it's called health-related quality of life. So if you look at this number, so a high quality of life is what you see in healthy children and healthy adults. So there's like a number we give, like 100 being the best and of course 0 being the worst. But if you're a healthy child or adult, your quality of life is superb. For example, next you see a child who's finished treatment for cancer or cystic fibrosis, they have numbers in between the 70 and the 80. Sickle cell disease is here, somewhere close to where patients who are on cancer treatment feel, how they feel. That's how difficult this is for children and adults living with sickle cell anemia. So what happens as the result is that we do a measure called QALE, a quality of life adjusted expectancy. When you're living with all these difficulties and challenges and limitations, it almost feels like then the life expectancy is only like 33 for healthy, good quality life. And that's why I think this chart is important. Look at the general population. 70s, yes, people get disease with old age and their number drops only slightly. And even though there's a 2-decade difference there, we see the quality adjusted life expectancy is almost a 3-decade difference there. And that is what we need to improve. We can't improve unless some patients actually come to us to seek the care so we can check them out and help them. And this is what is important for children and families to realize, that they continue to need to see a hematologist for their care moving forward year over year, all the way out. In fact, I mentioned the California cohort. California has a large sickle cell population. When they started doing the studies, 50% of the probable sickle cell population lived in the Los Angeles County, and they didn't have a single adult sickle cell clinic there. So only when people try to see what's out there, only when people try to seek care, they find difficulties, and that discourages them more. So this is why I spent a little time on life expectancy. It's not a straightforward, yeah, I have this and not going to live long, but actually there's a lot of things that impact this. And we and organizations like Carla's and Ray's are going to actually help you get the resources you need to seek out the care you need so you can actually improve your chances of staying healthy longer. Moving on, I'm just going to mention a little bit about chronic pain. This is one of the things I mentioned, although this is, again, what I'm focusing mostly on are some things that may present acutely, meaning suddenly, but actually are the result of chronic complications of sickle cell anemia over time. We all talk about the acute pain. We don't talk much about the chronic pain. And sometimes as a chronic pain symptom is evolving, we even tell ourselves and patients, well, that's not classic for sickle cell. That's not what sickle cell does. In a sense, you are not treating that adequately, not addressing it adequately, and that chronic pain is very, very disabling in the long run. It can start as early as childhood. And we do have a few patients in our practice who see other specialists to help them with that. A chronic pain, it refers to pain that is present on most days and has lasted at least 6 months without any other reason. And if you see in adulthood, almost half patients experience pain on more than half of the days. Almost a third report pain on 95% of days. That's how bad chronic pain can be. Obviously, the true prevalence is actually underappreciated because most patients manage their pain at home. They don't tell anyone. They learn to live with it, unfortunately, and that should not be the case. There actually was a study done about pain in sickle cell, epidemiology study, and they checked 260 patients. Many of the factors contribute to the difficulties that patients face in taking, seeking care. 40% had household income less than 10,000, 21% had less than 30,000, 30% had depression at baseline. So there are a lot of challenges then we can foresee in just chronic pain. And the type of pain is quite widespread, from the shins, the lower back, thighs, upper back. That can be quite disabling in terms of whether it's work or school. And that's one of the reasons they can't find good work and maintain it. And this pain is not managed like we do in the hospital, right? We just bring you in the hospital, give you pain medicine, and you're better, and you're gone home. You just need the hematologist, and the nurse is taking care of you. But in chronic pain, you really need a lot more support. The hematology team is just one component of everything else that needs to be done, from mental health, to physical therapy, to pain specialists, how we coordinate your care when you visit the emergency room with acute pain while you've been experiencing chronic pain. Community-based organizations like you do a great job with that. Addressing other side effects of treatments, social and support services, all these things are required to manage this chronic pain and to prevent that from accessing the best health possible. So again, we have a plan on the medical side as to how we would medically manage this and what medical support systems are available, but it is for you to come and see us, come and see the specialists. It might seem like, a big circus seeing so many people, but I think I want everyone to understand that this is what's needed to get the best care. And it's not medications only, but there's a whole bunch of things we can do. Next, chronic organ complications, or what I call chronic organ failure. We all know that sickle cell crises happen in many organs throughout your lifetime. And that's the reason for sometimes an acute complication, but more importantly for the chronic complication. A very simple example all of us with young children with sickle cell anemia know is that everybody's on penicillin for the first 5 years of life and give you special vaccinations. And why is that? Because of chronic organ failure with respect to the spleen. The tiny crises happening in the spleen are going to reduce the way your spleen can work effectively against certain infections. And that happens as early as age 2, 3, and 4, and 5, which is why we did the penicillin trials and the vaccine protections. Primarily because of that, we've been able to improve the survival of children to age 18 because of those interventions. But that's just an example of what we already know is a chronic organ failure that happens very, very early in life. And there are many more like that. Look at this chart. This actually chart shows on the x-axis, children's ages, age less than 6, 6 to 17, 18 to 29, 30 to 50, and over 50. And each bar represents an example of a chronic complication. The blue is pneumonia or acute chest syndrome. You can see it happens across all ages. Asthma, gallstones, kidney disease. You can see that the purple starts rising up rapidly from age 18 to 29, 30 to 50, and more than 50. Bone, avascular necrosis, and so on and so forth. So you can see that these problems cluster more and increase in percentage as you get older. Is that because of the history of the disease? Is that because of poor care and poor management? It could be both. And the key term here, I want you to remember, this is the most important slide if you want to think about how this is going to affect your long-term while producing minimal side effects. One is the important concept being it is irreversible. You cannot reverse the organ damage when it has progressed beyond a certain point. No matter what medicine you give, it is irreversible. CVA refers to the effects in the brain, like a stroke, for example. By the time you have a stroke, the disease is already advanced far enough that you're only treating the acute stroke, but you will never be able to prevent necessarily another stroke. Renal failure, kidney failure, again, another silent killer. You don't know it's coming on. You have no symptoms until your kidneys have failed dramatically and have only less than 10% function. Leg ulcers, eye disease, and also chronic lung disease. These are 8 chronic organ failures that produce minimal symptoms until they're advanced enough to cause symptoms. Even gallstones. By the time you have a symptom from a gallstone, the gallstone's already formed. It can cause problems that, sometimes damage the pancreas, damage the liver, cause you to undergo surgery in an emergency. So very unfavorable effects. It's not an acute complication. It's a chronic complication. Leg ulcers, I'll talk about this in a little bit because it's not very often seen in the pediatric population. Why are these important to know? Because what people have seen is they've tracked patients who have poor outcomes, including deaths from sickle cell anemia. And in this particular study, for example, they saw that if they took 232 patients who died with sickle cell disease, 170 of them, which is 73% of them, they had some irreversible organ damage already happened once, which means if you have an irreversible organ damage happen to you, it actually increases your chance of dying from sickle cell anemia. Of course, it depends on what type of disease, but some diseases are in that sense benign, much more benign than some others. But you can see that, for example, when people have kidney failure, that's 50% to 50%, 29% chance of, having a risk of increased risk of death. So having one organ chronic damage means your sickle cell has been either poorly managed or poorly taken care of, or not very effective treatments were given. So any organ damage should be taken seriously. But I just want to also mention to you that an organ damage is irreversible, but only at a certain level of severity. So if you have grade 1, grade 2, grade 3, grade 4, and 3 and 4 are the worst, if it's 3 or 4, it's very hard to reverse it, but definitely early on, you can slow down the progression even if you can't reverse it. You don't have to live in fear that you got one organ damage, you're going to die. It's not that. I'm just suggesting that because these can be detected early by screening and can be controlled to prevent progression, there's a lot you can do. But in patients who are not able to do that, they seem to have a higher risk of other problems and also death ultimately. talk a little bit about chronic organ failure with respect to brain. And here's a chart that shows on the x-axis ages of sickle cell disease patients, age less than 5 all the way to 55 to 59. And you can see the first gray bar here is cerebral infarction, which is a stroke. The risk of stroke is highest in children under the age of 10, and then it again increases between 20 and 29, and then decreases after that. The fact that this is high in children under 10, that means, and I mentioned earlier, that the process that causes a stroke in the blood vessels has started very early. We see this in sometimes children as young as 5, 4, and 6. It's already happened, the changes from the disease in the blood vessels in the brain. And there are different types of strokes you can have. What's called a hemorrhagic stroke, where there's bleeding into the brain, or an ischemic stroke, where there's just no blood flowing to that part of the brain. We all know the complication symptoms, stroke presenting as weakness or paralysis. And we call this condition myomeia when it's very advanced. There's also what's called a silent stroke, which happens in parts of the brain that don't produce any kind of movements. For example, in the frontal lobe, in the front part of your brain, which affects your memory, learning, thought processes, and that leads to children sometimes not doing well in school. And they have what's called cognitive difficulties that I've mentioned here. So they are a straight A student, suddenly in 7th grade, they start becoming a C or a D student, and that's probably because they've experienced a stroke in parts of the brain which did not produce any visible stroke outside for you. But if you have a seizure, if you have what's called a transient attack, which is you get a little weakness and then suddenly goes away in a few hours, and you might think, hey, that's nothing, but that is very serious. You can also develop aneurysms, which can bleed when the blood pressure is high. And of course, we detect these by doing this test called Transcranial Doppler. So there is something we can do to screen for this early and catch it early and intervene to reduce the progression of these changes over time. But the fact is that this can be quite devastating. We saw this slide earlier. So in general, a silent infarct causes a steep decline in function. So learning, thought process, memory, keeping jobs, attention, also is a risk factor for early dementia. 15% of the adult population has had a silent stroke that you can see on scan, even if you just did one routine scan, not for symptoms. And again, like I said, the highest risk of stroke, is maximal, by age 45, and it peaks in the 20 to 29 age group. The risk of a stroke that bleeds into the brain is 30 times higher in patients with sickle cell compared to those who don't have sickle cell. An important point here is blood pressure management. And we often know that children with sickle cell anemia have hypertension defined, when it's a normal blood pressure for a child without sickle cell of their own age. So what might be a normal blood pressure for a child without sickle cell is considered high blood pressure, because the blood pressure for average sickle cell anemia is lower than normal by about 10 to 15%. So do not ignore this risk of hypertension, and the treatment for hypertension can lead to a risk of stroke and bleeding in the brain. So again, even if you take adults with sickle cell anemia and you just randomly did an MRI on sickle cell anemia patients, 10% of aneurysms, which are like weaknesses in the blood vessel that can pop and bleed and cause a dangerous bleeding and into the brain. In the cooperative study on sickle cell anemia, we had 22% of people had signs of quiet or silent infarction. It was seen in 13% of children who had no history of stroke at all. Interesting thing is there are no screening recommendations to look for injury or cognitive defects in the adults. In children, we do these things, but the adults don't have a standard. So it may be too late if you just don't go to take yourself to a regular hematologist who can know how to screen. And hematologists will screen, primary care physicians do not know to screen. There are no expert panel recommendations for adults here. That's probably why. The next one I want to talk about a little bit is eyes, chronic organ failure in the eyes. This is another one that is very, very important, and this affects patients with SC even more sometimes than patients of SS. Now, what is important to remember that your eyesight may remain fine until very late. In fact, 95% of patients will have a normal eyesight when we first detect that there is something wrong in the eyes because of sickle cell anemia. There are different types of changes that occur inside the eyes, and this can only be detected unless it's very advanced, by an ophthalmologist. They can detect the earliest sign. I have in this next slide, this is the inside picture of the eye, of a normal eye. And you can see here that this eye has had small bleeds and a big bleed, we call it a Salmon patch. And you can see it on this angiogram that does a little bleed. And then as the thing progresses, the body starts to make new blood cells, which can bleed some more. And that bleeding leads to what's called detachment of retina, which leads to blindness. You can catch these early if you get screened. So important to get the screening suggestion done. If your ophthalmologist says come back in 6 months, because some of them will regress, some of them will progress, and you don't know if you don't make your appointments in time. Again, there are some things that we cannot control, but we can detect early and protect the eye. In the interest of time, I'll go quickly through lungs. Here's another organ that is usually not a focus of many of our conversations initially. And we might talk about it when you have an admission with pain and pain crisis and talk about a condition called acute chest syndrome, but chronically the lung is damaged by acute and chronic problems. There is a condition called pulmonary hypertension, which means the blood pressure of the blood vessel going to the lungs is very high. And that causes a back pressure on the heart and can lead to a problem. So I want to show you here the example here. In picture A, you see two labels. One is called AA, or the aorta, and then the PA, or the pulmonary artery. The pulmonary artery is what takes blood into the lungs. The pulmonary artery is usually smaller than the aorta. In this case, it is so much bigger than the aorta because there's pulmonary hypertension. And also when this happens, there's big blood vessels inside the lungs, and there's very little blood in the outside of the lungs. If you are diagnosed with this condition called pulmonary hypertension, the survival is quite bad at 5 years after you're diagnosed, because again, remember, I've been talking about these things that are irreversible. And so, but even if you compare this condition, which is serious enough in patients who don't have sickle cell, you see here that at 5 years after diagnosis of pulmonary hypertension, only 63% of patients with sickle cell anemia are alive compared to 83% without sickle cell anemia. So this progression can be quite rapid, and there are medications available. We won't talk about them, but the important thing is to see if this is there, this is happening in you, and that can be done with an echocardiogram. I'm not talking all doom and gloom. I'm talking about how to catch these things early because they don't produce symptoms. Your lungs scar from an acute chest syndrome. Sometimes we'll make recommendations for treatments. If you're not following with treatments regularly, the lungs do develop this complication over time. Another condition called pulmonary embolism, which you probably are more familiar with in the adult population. That's blood clots. Children with sickle cell disease are at a higher risk for blood clots. And the pulmonary embolism can also take parts of your lungs out. And acute chest on top can cause scarring in the lungs, all of which lead to pulmonary hypertension. Again, these are irreversible. So please remember that when you get recommended to get it screened for, you do that. Next one, chronic organ failure, kidneys. Here's another very, very important silent killer. Acute renal failure can happen, obviously, but chronic renal failure is the one that I'm most concerned. Acute renal failure will catch it, will reverse it. Chronic renal failure produces no symptoms until very late. Other things that happen when kidneys are affected by sickle cell anemia are blood in the urine or protein in the urine. A large amount of protein in the urine leads to what's called nephrotic syndrome. But chronic renal failure is the one you have to dread. Why? 25% of older sickle cell adults have chronic kidney disease. And once they have chronic kidney disease, that is responsible for half the deaths in that population. Not any other sickle cell complication, but just the kidney disease itself. The 5-year survival after a diagnosis of chronic severe renal failure is about only 55%. So only half of them are alive at 5 years after the diagnosis. And it can be detected very, very early. Screening and early diagnosis is something we recommend. We do it every year, starting at age 7, 8, or 9. And just like the eye exam, just like the pulmonary hypertension screening, it is something that we can check. If you have blood pressure, that could also be a sign of the kidneys being affected. So again, remember, there are risk factors that can be screened for because they don't cause any symptoms. The only way to catch them early is to screen for them. Lastly, 1 minute, I'll give, then I stop, to ask some questions. This is a leg of a child, and you can see how there's a huge amount of skin breakdown here. That is called an ulceration. it's a really big deal for people with sickle cell anemia. Again, something that's seen, past age, older adolescents, young adults. This is called a sickle cell leg ulcer, and it can affect 15 out of 100 people after the age of 20. It starts out as a small area of skin breakdown on the inside of your leg, and it keeps growing because of lack of blood supply, because of circulation in that area. There's very few things that can help you fix it unless you do it very early. But the point is, it can lead to a lot of difficulties with, adjusting to normal daily activities and maintaining a healthy lifestyle. So, I mean, this might be more of a nuisance, but the other ones that we talked about are really serious conditions. And I hope that we all remember that, and remember the advice for screening, advice for medications, and do that not just when you're a child, your parents bring you in, but as you become an adolescent and a young adult and continue to care for yourself, make sure you ask for these things. Make sure you seek out the consultation of a hematologist. It is a statistic that only 20 to 30% of sickle cell anemia patients are actually followed by a hematologist. The rest are all followed by a primary care physician. Of course, there are some great primary care physicians that do a great job, but the screening protocols and comprehensive clinics that are available to the big programs, they give you a lot of advantage in picking things up early, and you can follow through with that. So you can be one of those octogenarians, that we talked about. And I hope that we can make a further dent into improving the expectancy and also the quality of life. These go hand in hand, right? So I just want to stop there and see if people have any questions. I'm happy to answer questions now or later. But I do thank you for your time. And if you have any questions later, you can always reach out to me through Carla, through my email or phone number. Thank you for the opportunity. I appreciate it.
Dr. Naga, this was amazing. I do have a question as Carla comes online. You talked early on about the health-related quality of life, and that is such an important study that I think is something that we have not, as a community, really taken a look at, because how medical professionals measure quality of life may be vastly different than how community members measure quality of life, and even health-related quality of life. So that's one point that I want to make, is that I think that there's potentially some room to take a look at what we have historically used as measurements of quality of life and involve community voices in that to impact that, because many health decisions are made from that scale there. And then the other piece is that a lot of it measures, from what I've seen, measures quality of life and health-related quality of life from a pediatric perspective. So even on that scale that you showed, I'm not sure that reflects adult health-related quality of life on that scale of 0 to 100, right? And we know that there's a vast difference between adult and children living with sickle cell disease. Do you know if there are any comparative studies that may have different results?
Well, those are good questions and a good point. I do think that that we are constantly refining our quality of life questionnaires. In fact, they're not even designed by, medical physicians anymore. They're designed by psychologists who look at, accepted World Health Organization stated, quality of life measures for the global community, not just, for example, the United States population. And what I tried to do today was try to pull a lot of my data from the adult studies. And so the SWAY study that I mentioned was actually 2,000 adult patients. And many of the other graphs that I referred to were from that. The cohort studies, although it might seem like it's a pediatric cohort or the neonatal cohort, it actually follow-up of patients way past the pediatric ages. But yes, some of it does include pediatric data, but a lot of it actually what I pulled was adult data, but it is undergoing constant revision. Again, some of these studies are very hard to do. You can see in that large international study, 16 centers, only 2,000 patients. So I think there is underreporting, there is definitely underappreciation of the challenges. And I think what we are seeing, I would say, is only the tip of the iceberg. You're right. We just finding what's on top. That's not it. We can't be happy with that. We have to find out exactly how much more that is. And really, there are a lot of people who don't respond who probably have a much worse quality of life. I do appreciate that perspective.
Thank you for that response.
Thank you so much, Dr. Naga. I also have a question. When I was thinking about quality of life and the quality of life, particularly in children, and I'm really really got educated today on this health quality of life, because we knew that there is some difference, and there is definitely studies on the quality of life. And but just to see the study in fruition, that was really awesome to see. One of the questions that I have is the discussions with the patients. So in order to educate them on, and I think this is part mentally too, in drawing in a social worker as well as a mental health provider, having discussions on quality of life prior to, so because we know that so much how the disease have impacts even in children. And when I thought about this particular, I remember a time when my son was having a challenging time in the hospital, and at the time he was 12. And during that time, I remember him coming to me and said, "I'm not living my life." And at that point, I'm just looking at him, and I was heartbroken for him to say that to me, because I understood what he meant, but I questioned him more to see if he understand. So I asked him at the time, I said, "So what do you mean?" And he said, that time I had him as a hospital homebound student also, so he couldn't go to school with his peers. And he said, "I'm not going to school like my siblings, and I want to go to school like my siblings." And I said, "But I'm here with you. Mommy's adjusted her work schedule, so we have more time together." And he made sure to tell me it's not the same, So I think even earlier on, just having conversations with our children about quality of life and how it may look different, but definitely also bringing in a mental health specialist. Because then at that point, of course, I contacted a mental health specialist and talked a little further about him, and then tried to schedule a visit, because I said, no, I definitely, as a parent, need to make sure he has the necessary support possible. So thank you so much for that.
Sure. We have, at least in our practice, we have just added a licensed mental health social worker, and now we have additional coverage for our families to be screened for these risk factors and also educated upon it. Our team up north also is very focused on cancer care delivery research and healthcare delivery research in general, and they developed a tool called the Psychosocial Assessment tool, which we haven't implemented, but which we soon will, which actually assesses and it's been validated for sickle cell anemia as well, including through patients enrolled from our site. And that is a screening tool that we're going to use on every new patient or family that comes into our practice, but also on a periodic basis to see if the family and the child are going through a psychosocial risk scenario that needs addressing. But often, sometimes even the child or the parent is uncomfortable talking to the healthcare provider. And in our busy thing, we might just ignore it or neglect it in some way, unfortunately. But we are making sure, at least I've been making sure in the last couple of months, that our social work has always gone into the room after we have left the room to see what the family's needs are, the child's needs are. It's an important point. Like I said, the healthcare provider is just one component of the important circle of care you need, not just for chronic pain management, but just for everything. I think what you mentioned is often a big gap in many places, including at our site, but also in the bigger programs where those things, because they don't produce billable revenue, are not hired adequately and staffed adequately. So there's a standard of care that's being published for what should be the level of mental health support for, say, cancer patients, but there's not one done yet for, say, chronic diseases like sickle cell anemia. I think that's an important component of, again, gaps in care that people should focus on as they try to develop and build and grow their programs to help patients.
Thank you so much. Thank you so much for sharing that. And I've seen some other, I have a other question I had was, you gave some interesting information about leg ulcers.
Mhm.
And I was wondering, and I've been seeing so much concern, even with our older adults, on, care thereafter. Is there anything that we should know or be aware of before it gets to that, point that that is such an open wound to care for? What should we be looking for, even as parents, as patients? Just any signs that we should address with our physicians.
Sure. Well, good point. Actually, any discoloration of the skin on the inside aspect of your ankle is usually the first sign of something underlying, which is called as a venous insufficiency. I mean, there's not enough, blood flowing or going away, taking the oxygen. So discoloration of skin, then followed by a breakdown of the skin, it's something that would be, you have to pay urgent attention to. And having said that, you could have a breakdown from just a casual trauma that's not necessarily going to cause a venous ulcer there, but because of that location, if it happened in your upper arm versus the lower leg, I think you should be more careful about something that happens to any skin breakdown in the lower leg, especially at the lowest part of your leg. So any skin breakdown there, whether it's traumatic or not, any skin discoloration or other things in the leg area should be promptly brought to the attention of. And then as far as reducing the risk of traumatic injury there, I would say as children participate in activities, whether it's casual or mild activities, physical activities, make sure they're wearing the protective gear, appropriate, shoes and, things like that, so they can minimize the risk of trauma to that region.
Thank you. And then you mentioned also in silent damage, you also mentioned just screening for high blood pressure. And I was wondering, and even for younger children, because not really surprising to me, but it just kind of caught me off guard. When my son was 9, he was diagnosed with high blood pressure. Is there anything for me as a parent? And it took a couple visits, of course, to the doctor, because they just from natural screening and visits with you, the hematologist, and also his pediatric doctor. So is there anything for me as a parent that I should be aware of or should have been aware of prior? Because when I said he was 9 when that particular diagnosis came on, and I thought to myself, what did I miss?
Sure.
Was there something I could have done?
No, that's a good question. And often for everything else, parents, try to feel the guilt, but obviously, it could be, it's easily somebody else's, error as well. I would say that, first of all, it should be common knowledge, but it is not, maybe with some pediatricians, for example, or primary care physicians or family practitioners, that a normal blood pressure in a sickle cell anemia child, it could actually be high for them, normal by age and gender. And there are no, like, for example, if you take a new 6-year-old boy walking into the clinic, you could actually plot them on there's a curve for that. The doctors can plot them and it's like, oh, this is more than 95th percentile, just like we check height and weight. There's no such graph for children with sickle cell anemia. So it's your inherent knowledge that, if you are not at least 15 to 20% below the numbers for your average age and gender, then you're okay and normal. And if not, then it is abnormal. As I said, it takes a few repetitions before we call somebody as having persistent hypertension, but just the knowledge is sometimes lacking, the awareness is lacking. And so it might sometimes get blown off and you might think it is normal, the parent was advised as such, but it's something to be aware of and bring up for discussion, like you said, well, it's abnormal. And like I said, it doesn't get flagged as abnormal in the chart, so there's no way for you to know except to ask the doctor anytime the blood pressure is recorded. Of course, during an acute crisis, the blood pressure is going to be high because the child is in pain or stressed. But in a steady state, it should be within 15% of the upper limit of normal for the child's age and gender. So all you can do is bring awareness to it during discussions with your physician.
Yes. Thank you
I think
so
you're making,
much.
oh, I'm sorry. I think you're making really good points because this is the importance of being that empowered caregiver, right? There's so many things that, it feels like we don't know until we should have known them already. And some things we just don't have that control over, but it's that ongoing dialogue. It's that, what are the risk factors at this age group, not just this age right
Yes.
now? What are the things that I as a parent can be looking for? But it's also recognizing, and you are very informed, Dr. Naga, because it's important that pediatric hematologists are working closely with adult hematologists so that they understand what are the risk factors on the adult side that we may not
Yes.
see. We may not have to pay a lot of attention to, but we have a role as pediatric providers in sharing this information upstream with the families so that they know. And so I think that that's something else that we as a community can push for. You as a physician advocate can push for. How do we ensure that those communications are going on so that that's one of the gaps that we
Right.
see in transition. So
Sure. And I'm happy to share that gap should be narrowing, more and more because there is more and more collaboration with adults. There are more clinical trials, there are more studies. In fact, the very dreadful condition called pulmonary hypertension that I mentioned, and I had the chance to work with some of the leading investigators in this field when I was in Chicago for clinical trials. It's always thought of as an adult problem or a condition. But once we realized, and we brought that trial to children, we realized by screening children, 15% of them with acute chest syndrome or asthma or sleep apnea had pulmonary hypertension.
Mm.
So that became added to our, armamentarium or tool. So, we've started very closely looking at, like I said, the lack of standard cohorts for regular follow-up and this disconnect between adult and pediatric practitioners, is something that needs to be narrowed. The American Society for Hematology has created a sickle cell collaborative, a great push for sickle cell research, and is identifying, programs that we call clinical trial units, which will include both adult and pediatric patients in clinical trials, so they can learn more about these things on a rapid basis. Otherwise, it just happens to get learned in a select few centers who have the wherewithal to write grants and funds. But I think that there are gaps. I agree, there are gaps, and we need to sort of collaborate more and learn more.
excellent. And it looks like we have a question from someone in the audience. So go ahead and unmute yourself first and then ask your question.
Hi, can you guys hear me?
We sure
Yes.
can.
Okay. Hi, Dr. Naga. I just want to say thank you. I want to say thank you to Miss Ray and to Miss Carla for having this. I am a parent of a warrior who is 13 years old and he has S beta 0 thalassemia. And we have been through so many hurdles. We finally got it diagnosed that he has chronic pain on top of his sickle cell pain. And he knows the difference between his acute pain and his chronic pain. And we notice that sometimes when we go to the ER, they don't understand that when a kid comes in who knows about their disease, and sometimes it becomes a battle. I found that I have had to befriend certain doctors so that they could come and fight on our behalf, like and put in charts, like don't even with things as small as we're trying to prevent him from getting a port, only let the IV team stick him, because if I say it as a parent, it's like, oh, she's that mom type thing. And it's no,
Mm.
you guys might see a vein and the vein might be collapsed, and then he's telling you that's not where they usually stick me, and you're looking at him funny like you don't know, you're not the professional type thing. So we've always been in that
Wow.
kind of battle. But this chronic pain has been like, it seems worse than the sickle cell, because it was hard for him to function in school. We knew early on, like from when he was little, when it would be cold outside, I would put I would make our house where it didn't look like a home. Like we would have blankets up to the windows to keep the draft out, a big blanket up against the door to keep the draft out. And his body could still tell that, hey, it's cold outside. So my knees are gonna hurt, my back is gonna hurt. And from like we started hydroxyurea, and then all of a sudden one day he couldn't walk, but he was walking. We would exercise because his aunts, they have sickle cell, and I just noticed they weren't moving around much. They weren't eating, we went vegan, so they weren't eating, they were eating McDonald's and Wendy's. So my husband and I was like, well, let's just try to do the opposite of what they're doing, and let's see if we get like a different effect. And my doctor
Mm,
got all upset because we were juicing and things like that. And he wanted us to take like all the medications. And I was like, well, why can't we do both? So like early on, we had issues, but now they're like, oh yeah, let's get a nutritionist on the team. Let's
mm,
do these things. So I can see the advancement, but at first things were met with a wall, as in like CBD oil. Like, no, if you take CBD oil, then you cannot get oxycodone. And my child's on methadone as well. So you cannot get oxycodone, you cannot get methadone. And it's like, oh, okay, well, I'm trying to help you help him stay out of the hospital, because at home we're on oxycodone, but in the hospital now we're on Dilaudid. And then when you send him home, I gotta deal with,
mm,
him throwing up and being sick because his body still wants the Dilaudid.
yeah.
So when we finally got the chronic pain diagnosis, um, it helped me because he had become suicidal. And my daughter, she was 5 years old, she walked in on him trying to harm himself.
Mm,
And then I was like, as a mom, like in the Black community, like you don't tell that part of your business. But I was like on the trend of doing things the opposite of how everybody else does it. I went to the medical team and said, hey, I've been telling you guys from the start that he's been hurting, and we're trying to keep him out of the hospital, but now it's led to this. What do I do? And so they suggested a psychologist, but not just any psychologist, just one that dealt with sickle cell and cancer. And she's amazing.
mm,
She looked at our situation and she's like, hey, if you like me, you can stay. If you don't, I understand. But we end up liking her. It's been like 5 years we've been dealing with her. And she looks at my son and she'll say, like, if he needs me, have him text me. So they have that kind of relationship. And I just feel strongly that us parents, we need to build relationships, because sickle cell is not a 8 o'clock to five
mhm,
o'clock clinic thing. There's still ongoing things that happen. And as parents, we kind of have to adjust our lives. My child can't go to school like a regular kid. If it's raining outside, he's going to be hurting. It's going to hit him in his back, and he's in a wheelchair and a walker. But for him, he just said school is not for me. So I had to learn and work with the psychologist. They like encouraged me, go ahead on and do homeschool. And I'm like, no, that's not for me. I don't know how to do that. But I end up welcoming it. And his doctors, at
mhm,
first, they were like, nah, we think he needs to go to school and be with his peers. But I think one big thing about sickle cell is it's an individual disease, and it affects everybody in different ways. And then it grows with you. So when you were talking about the chronic pain, for us, the chronic pain is led to, you have to take methadone. That makes you constipated. That increases the priapism. And
mhm,
now, like, we're dealing with bladder and kidney issues all at 13. So, I'm in Georgia, and in Georgia, the doctors have now partnered with Grady, with the adult hospitals. And now you have a rotation where the doctors from Grady come in and they go through all your medications. My kid's on like 30 something medications, and they go through all the medications and say, hey, we noticed that the kids who take this, by the time they get to Grady, their
mhm,
kidneys are messed up. We need to do something here. We need to change this around. So right now he just turned 13. So we're in that loop. So everything that you've said today, I'm noticing the shift, but it's for
Super.
our kids who are older, it's really like, it's really sad because it's a little late. I'm
Yeah.
happy that it's it's happening, but it's a little late because the organs have already taken a hit. So I just really wanted to say thank you. And like the blood pressure, all of your charts, I was trying to catch them because those were all the, we just had an appointment on Friday, and those were all the questions that I had for them, that they were like, well, when you go see nephrology, go talk to the nephrologist. So we just did a urine, we'll
Mm.
check the urine and we'll get back to you. So it's a lot of open-ended where I'm just waiting for a phone call, or I'm digging in my chart trying to find the information myself. So I just want to thank you. I wish more parents would try to find resources like this to help their babies, because after a while, like my kid's 13, 5 years is going to be an adult, and I want to make sure that he has that foundation set that he can advocate for himself. So thank you.
Well, thanks for sharing that with us. It's definitely a very difficult journey you've gone through. And unfortunately, medical training really oftentimes lags behind, really what, patients teach us. And I learned a lot more in my practice years than when I trained. And just because somebody's a card-carrying hematologist doesn't mean they know everything about sickle cell until they've actually seen families. And I have to oftentimes even correct my own trainees as to their perception of how they think the child is saying or reporting about things. Even how my other colleagues are, doing that. For some of these patients, it's best for them to have a care plan or an action plan that is shared with the multiple areas of the hospital that they touch, like the ER especially. The ER is a place where there's a lot of turnover, shifts change, days change, providers change. There are physician assistants, nurse practitioners, there are physicians, and not everyone can know or see everything in sickle cell. So we try to devise a care plan for these very complex patients. So, some patients, don't need the certain things, and some work well with others. And some of those things, again, we have learned as we have, become wiser because of our experience. But it is something that unfortunately some children and families have gone through to learn it the hard way, and it is a shame. But it's important to share your story. So to other families, other children, other adolescents who are listening in, please know that you need to be an advocate for your child. And if you're not getting the attention, your child deserves, then definitely seek someone who has more expertise than them.
Thank you so much, Dr. Naga. Thank you so much.
Yeah.
Could you pronounce your name? I don't want to mispronounce your name.
I'm going to try to get this close to the camera so everybody can also see what that is. It is, can you see it? Nagasubramanian.
Okay.
It's Nagasubramanian.
Yes. And we call him Dr. Naga for short.
Yes.
Thank you so much. And is that Mason? Myson?
My son is my child. I'm my
Okay.
Shauna. I'm
Shauna. Okay. Shauna, thank you so much, Shauna, for joining.
Yes.
And definitely you are an inspiration.
Yes.
Just looking resources for your child and just sharing your journey. We thank you for that. It's because of the needs of parents to be educated, and us, our personal experience, why we know that resources are needed. And you encourage and inspire us as parents, because the road doesn't get easy. We need the support. All of us do. Even on my journey of education, I'm still learning. I'm still seeking information. With sickle cell, it's an ongoing procedure in order to gather as much information as possible as we learn and support each other. So I appreciate you for joining us today. Dr. Naga, I know we're over time for having you. I don't know if Ray have a statement before we let you move on.
Yeah, I just want to say thank you, Dr. Naga. That was one of the most comprehensive presentations regarding complications, but it really gave your perspective, and how you presented it was what was important. Many of us have seen those slides, we've seen that data, but it's how you present that data. And it's really in talking about how do we get upstream of this? How do we talk about this? Not from just, not in order to create a doom and gloom feeling, but to say, this is something you should be aware of. This is something something you can ask your physician about. This is something you should think about as you get ready for transition. And so we appreciate that as a community, as caregivers. And then Shauna, you are amazing. I think that what really stands out for me about your story is that you continue to push, right? And though the physicians are medical experts, you are a parent expert, and you and your child together, you knew what you were seeing in your child. Your child was coming to you. I think that the two things that I pulled out, number one, you talked about CBD. That's a conversation we really must have.
Yes.
And though I understand that there is more medical research that's needed about drug interactions, I think it's important that we open these dialogues, because what we don't want to happen is where families feel like they can't share what their home remedies are for fear that they will not have the same access to certain treatments. And I would hate for that to happen. And I don't think that that's the route that needs to happen. So that is something that's important that we should continue to talk about. And then second of all, you talked about getting your son engaged in therapy and the impact, the positive impact that has had. And I don't know the exact age that he started, but I am of the mindset that we have to normalize it from the beginning. We can't wait until there's a fire in front of us that says, we better get our child into therapy, because by that time, now you're playing catch up. Now you're trying to repair something that's already broken. And if we introduce mental health supports early on, what we do from a very early age is, like I said, we normalize it, but we teach them how to think about, how to feel about, and how to talk about having a disease like sickle cell disease. And so thank you, 6 years old. That's a beautiful age, right around that time that they're starting school and they have to engage with other peers. And they see normal through the lens of someone else's life. They rarely see normal through their own lens of life. And so if we can normalize helping them to process those emotions, helping them to find the language and the words, and then helping them to identify what that feels like, and how to respond to those feelings in the most healthy way. We've got to address those things early on and not later on. So thank you so much for sharing. I think that you have an incredible platform, and I personally look forward to talking with you about ways that we can support you. Carla and I and the community at large can support you, but also how your story supports others as well.
Yes. Definitely. Thank you so much. And we're definitely going to be staying connected, because this is why we're here. Dr. Naga, thank you for joining us. I know you have to go. I appreciate your presentation so much, and your willingness to educate the community, and just your compassion for sickle cell disease is certainly presented here and beyond as you treat patients. So I thank you so much for joining us, and we will be in touch.
Thank you. Thanks very much.
You're welcome. At this time, I just want to, Dr. Naga, you have to share your host. You have to bring back the host to me.
Okay, let me see. What do I need to do? Stop sharing, right?
Yeah, you stop sharing. You can go down to, Ray, can you lead him on how to go back to the host to
if you click on participants, you'll see your name.
Yeah.
And then you may also see Carla's name. And if you click on more, is there an option to give her host or allow share screen?
I see more. Okay.
And then if you click on that, does it give you any options under that?
No, it just gives me an option. Sorry, it says host. How do I change myself to not being a host?
So if you click on her for host.
Oh, her. Okay.
Her. Yeah.
I see. Make host.
Yes. There you go.
Yep.
Good. I was about to log off, so I'm
yeah, really.
Thank you.
Thank you so much. Thank you so much.
Bye.
I appreciate it.
Thank you.
Bye. Yes. So at this time, I thank you so much. I will be sharing my screen. 1 second.
And I just want to remind anyone who may join late that we are here for the third session of our Empowered Caregiver session. We just heard from Dr. Naga of Nemours Children, who presented on sickle cell silent damage. An excellent presentation. If you're just joining, rewind, listen to that presentation.
Yes.
So much good information. We heard from the mother of a 13-year-old young man living with sickle cell disease and her experiences regarding some of that silent damage, which frankly isn't so silent anymore for her. And so it was amazing hearing from her and her experiences and how she has advocated as a caregiver for her young son and how her young son has learned to advocate for himself, right? That your children may not advocate at the doctor's office, but they will advocate with you. How do you translate their language into something that the providers can hear and understand? They may not feel bold enough. They may not feel old enough. They may not feel like their voice is loud enough. They'll share it with you, but they may not say it in the doctor's office. But you are the voice of your children. But make sure that your voice reflects their voice, not just yours. So these conversations are so important. Thank you again for our previous speakers. And Carla, go ahead.
Thank you so much. Thank you to our partners for your overall support of this Empowered Caregivers sessions. We had 3 sessions. This is our 3rd one. Like Ray said, we are so thankful. Our gold sponsor, which is Mednick USA and Bloomberg Bio, we thank you. Our silver sponsor, GBT and Pharma Therapeutics, and our bronze sponsor, Trumo Blood and Cell Technologies, and Novartis. We thank you very much for your support and continual support to our sickle cell community. It's so important for us to gather information and resources, and we know that our partners really compassionately care about our community. So thank you again. I thank Dr. Naga, which presented on silent damage. We are so thankful. He is the division chief of pediatric hematology oncology at Nemours Children's Hospital. Now, we will go into our next session. Let's talk about it, insights in reducing pain. But first, we're going to take a 5-minute break. So we will get back to you on our presentation in a few minutes. I am going to let. So thank you. So we are going to take a 5-minute break at this time, and then we are going to continue. So 5 minutes, and we shall be back with our community conversations. And we have a few that joined us. We have some prizes that we are introducing, so you will want to come back. We're going to do our trivia when we come back, so you will want to join us. Don't miss it. So we'll take a 5-minute break. Thank you.
Oh, I'm so happy to get in there.
Were you waiting a little while? Welcome, Renee.
Oh, thank you.
Welcome back, everyone. Welcome back. Welcome back. We thank you for joining our third session of Empowered Caregivers Forum. We thank you again for being here. And we've been having a great morning. So this continuation is definitely going to enlighten us as we stay connected. And I just want to give an opportunity because we do connections. So I just want to give an opportunity for our guests to just share our new guest that just joined. That's if you would like, if you can share where you're from and your relation to sickle cell, you can put it in the chat and also unmute yourself. We want to stay connected and thank you for joining us.
Hello, Renee Kirby from California. I have sickle cell SE.
Welcome, Renee. Thank you for joining us again.
Yes.
Renee was on
like,
our last session.
Yeah, it's like I enjoyed you guys. I was like, I hope I can get in. So I was like Googling and trying to figure. I'm like, okay, I don't have Twitter, so let me try and find a Twitter account. So I like emailed. Because I was in the waiting room and I was like, hello, anybody?
Oh, we had another presenter that had host, so I'm sorry about that. So
okay.
I'm glad you stuck in here
to
to join us. But I will make sure you have my admin email, which I check frequently, and also my contact, so you can also definitely get in touch with us when we have any issues. So we know there's technical things that we're trying to learn this new Zoom world.
Yes. And
so we expect the unexpected.
I was like, oh no, my husband's not home. He's at a soccer match.
Thank you so much.
Oh, thank you.
Renee, thank you so much for joining. And if you could just put on what is it? Where you said you're from California?
Oh, sorry. Yes, I'm from Central Coast, San Luis Obispo.
Okay. And what's your relation to sickle cell?
I have SC.
Okay, SC Warrior. Welcome, Warrior. We appreciate you for joining, and we thank you so much for coming on.
How old are you, Renee?
I'm 47.
Wow, you could teach us a lot, right? That's the beauty of the community, is we all learn from each other. And, a warrior in their 40s has experienced things and that caregivers care about. And so thank you for joining us.
This is my first year of advocacy. I've been kind of like most people hiding it, but I said this year I'm coming out.
Good job.
Nice.
We're here to support you do that.
Thank you, ladies.
Definitely, definitely. So we'll be starting our session in a few seconds, but first we are going to go to our first trivia session. I wanted to just take the time right now and just go back and thank our sponsors. And we're very thankful for the overall support of our sponsors: Medwick, Bluebird Medical USA, Bluebird Bio, GBT, Pharma Therapeutics, Trumo, Blood and Cell Technologies, and also Novartis. So I just wanted to take the time to just thank our supporters. We thank you very much for your overall support. We had just to recap, we had a previous presentation by Dr. Naga, which was great, which was the sickle cell, the silent damage. It was truly awesome and an inspirational presentation to help us learn so much about the silent damages of sickle cell. If you did not get to see that, we definitely will have this on YouTube for your viewing, and you can also go back and watch that. So our trivia question, which will also present a prize. Which part of the blood is affected in sickle cell disease? It's a two-part question. And what is its role? Please type in the chat. Hey, Ray, can you see the chat? Because I can't right now.
I sure can. And let's see, it looks like we have a couple of responses already. So Shauna, red blood cells and it carries oxygen throughout the body. Excellent. That's correct.
Yes.
Yes.
Great.
And what is the and you've been in your my chart. So what's the code that how do doctors write oxygen?
Woo. Love it.
Yes, O2, because we have to know their language just like they need to know our language. So when we're reading our charts, and I recommend that everybody, whether you are a warrior or you are a caregiver, make sure that you have access to the medical charts. Read those charts, read the notes that were left. And yes, there are sometimes that they use, oh yeah, that is. So Shauna said it's kind of cheating for her because she's a respiratory therapist, and you're right, you guys do O2 constantly. So, but it is important that we recognize what is the terminology, what are the, how is it written in medical lingo, so that we know exactly what everything means. So yes, O2 is oxygen, and oxygen is a molecule in the red blood cell, and it carries oxygen throughout the body, particularly to the organs. Okay, organs function well with water and oxygen and all these other molecules, but oxygen is so important, and it is highly impacted in sickle cell disease.
Thank you so much, Shauna. We will be mailing out your gift, which is a $25 Bahama Breeze gift card. You had a two-part question and right through in the third. So we look forward to you dining and enjoying some self-care time at Bahama Breeze. So thank you so much for contributing to our trivia, and we look forward to you having some great self-care time. So we are going to start with our community conversation. Let's talk about it. Insights of reducing pain crisis and hospitalizations for patients and our patients and caregiver perspective. Let's talk about this. So we know that there are some times that require that patients go to the hospital, and we've been seeing studies about the sickle cell patients, the increase of hospitalizations and the decrease during the time of this pandemic. And now they started to see a rise, I want to say at during the mid 2021, they started to see a more increase as patients got more comfortable and they learned more about just being safe, right? So I just want to know just a little bit, we'll talk about just a little bit on what are the things to reduce pain as practices with sickle cell disease. I will first share, we know that hydration is very important. Had some conversations with some warriors that even go in for infusion hydration as a monthly treatment. So what are your thoughts on reducing pain crisis? What can you do, or what do you do that you would like to share?
Do we raise our hands? I don't know where that little hand guy is.
Yes.
Oh, sorry. Let me find it.
Go ahead and speak, Renee.
Oh,
I'm gonna stop
sorry.
sharing my screen.
I know for me, I try and avoid stress, and as much as possible, I like to stick to a schedule. I'm very type A, but that has its negative effects too, because type A is, we're kind of rigid people, so have to allow for flexibility. But and heat, I love heat. It's hydration, and just trying to maintain a stability, because we're in different environments. Make sure you have extra layers of clothing, nutritious diet. I think all those help build a healthy us.
Yes,
and staying on top of your
definitely.
medication. Don't chase it. If you're in pain, take the medication, which I'm a hardhead. I don't do. So I'm getting better at it after 30 years.
Thank you.
I'm a slow learner.
And that's an ongoing thing for, I think, a lot of warriors. I know my son is younger and he's adjusting now to just staying on top of his schedule. But the other day I just had a conversation with him. I said, I would like to know that when you're in pain, when you first wake up in pain, what is your routine? Because I realize sometimes I wouldn't know until it's like, go to the hospital. Can you take me in? Or we're at this point that I can see his pain has got so progressive, and I'm looking like, what did I miss here? You know, that is now a 8, and then it's time to call the doctor and me figure out things. So then I would ask him his routine, like, what time did you wake? I'm coming with the questions. What time did you wake up in pain? So now that he wasn't in pain, I had this conversation with him, because this is the conversation we have when he's in pain, right?
Right.
So I said, you know what? I need to have this conversation when he's not in pain, because he give me the answers when he's in pain. So I said, what is your routine? Because typically he wakes up in pain. It just doesn't come on day. So all of his crises seem to be wake. So what's your routine when you wake up? So he had to think about it, and he said, the first thing I do is get a heating pad. I get my heating pad on board for wherever the pain is. He said, the second thing I do, I'll take Tylenol. And I said, Tylenol, okay. So then I had a conversation. I said, so why not take, if it's that bad already, why are you not taking Motrin, ibuprofen? And he says, you know, I just want to start with Tylenol. And I thought to myself, I can see where he got that from, because when he was smaller, he did not need the pain meds that he needs now. So we did Tylenol and Motrin, that kind of solved it. And now when he was 12 and it got progressive, I'm like, I never gave you Tylenol when you turned 12. We started with ibuprofen, and then we went to your, it was morphine via mouth, our pill. So it was just like, I'm like a little off. And I said, well, you know, I had to talk to him about, okay, so getting the heating pad on board was great. Do you make sure you're drinking a lot of water while you're, you know, during this process of treatment? And he's like, yeah, I'm always have water at the side of my bed. And then I was talking about, what can we do a little differently? So let's start with maybe, if your pain is, you know, you feel that it's really progressive, and so maybe we should start with Dilaudid and then go to the ibuprofen, and we'll rotate those, but we're not going to do Tylenol. So we had to talk about what will our schedule be a little bit different in order to prepare him, because I want him to make sure he can do this on his own. We always talk about me not being present. Or what is it that maybe you can start with ibuprofen and then go to your Dilaudid, because he doesn't use morphine anymore. So your Dilaudid via mouth. And we spoke about different things. What else can you do? And he said, I also do put on my music, because that relaxes me and takes my mind off the pain. So I have certain music that I have downloaded. And I was like, wow, I have downloaded that tend to relax me. And I said, okay, that's good. And I said, and I had mentioned to him, I said, do you also watch TV at times or switch it up? He said, I don't want the TV on at all. I like my room. I don't want it dark. I don't open the shades. I kind of keep it mellowed so that I'm just in a relaxed mode. And I said, wow, I realized that, but it didn't trigger me, right? So I was really talking to him. I let me see what kind of atmosphere he has. So this way I don't interrupt that also. So Ray, you can probably share also too, what is it that your son does that we can learn from each other and, even, educate each other so we can be able to bring this back to our warriors and help our warrior community?
Yeah, thank you for that. My son had a really difficult start in life. And so his disease complexities from a very early age, I mean, his first hospitalization was at 4 months, and his first blood transfusion, the first time he went on, opioid medications, was at 4 months old. And so from very early on, I was very concerned that he couldn't communicate to me. So how am I going to communicate to him? And how am I going to teach him how to communicate to me when he's in pain? That was always my biggest fear. What if I don't know? So when he was very young, I started teaching him different sign language techniques to tell me if he was in pain. And so out of that, we created really an open dialogue of when you start having pain or when something is achy, let mama know, so that we can get upstream. I became very close friends with a pain specialist who was a nurse in pain care, in a pain clinic. And she would break down an understanding of how pain works in the body. And she would use these diagrams and these drawings, and she would reinforce to me the importance of hitting pain hard from the beginning. Don't wait until it maxes out in pain. If you don't, because your pain will last longer when you do it that way. But if you hit it hard in the beginning, and that's one of the challenges that the emergency rooms have. They want to take this slow start approach, and they want to say, well, let's start with something small and see if that helps. That doesn't help. We need you to hit it hard from the beginning. Move out of your brain this idea that you're giving too much, or that you're causing addiction, or that you're causing this. You can actually be doing more harm as a provider by taking it too slow in the beginning. By the time we go to the hospital, trust me, we've done all the little things at home. And they forget that piece, that by the time we see them, we need you to intervene on a much larger scale. And so we would do that at home. And then the other thing that I learned that I don't think is talked about a lot is that there are certain pain medications that are complementary to one another. So anytime we take, say, oxycodone, we pair that with Tylenol. Listen, we all know, everybody on this call knows Tylenol ain't doing nothing by itself. Nothing. That's for them other folks with a little headache or something. This is not a Tylenol kind of pain. It particularly by the time you reach chronic pain, that young adult years, your body has already been assaulted so many times that what you need to do is much larger than what Tylenol by itself can do. So we never, ever, ever take Tylenol alone. We always pair it with something else. Now, there may be times that he'll take Advil, or he can't do ibuprofen. So that's the other thing, is because he had so much pain from such a young age, his stomach is toe up from the flow up, right? Like tore up. And so he has to be very careful taking things like NSAIDs and ibuprofen, which ibuprofen is an NSAID, but non-steroidal anti-inflammatory. He needs the anti-inflammatory. We all need to make sure there's anti-inflammatories on board, because the sickle cell disease has an inflammatory underlying issue to it. However, how we take it, when we take it, how often we take it, what we pair it with, are we taking it with food? Are we not? All of those things matter in our digestive tract, which can cause other problems as well. That can sometimes the intensity of the pain from, say, stomach issues from having taken those medications can reflect the same thing as sickle cell pain. Like, it's that intense. So we have to be mindful of all of those things. But more importantly than anything, it's from a young age, teaching them how to communicate their pain so that we can intervene from early on rather than when they just can't tolerate it anymore. You're on mute.
You think I would get used to this by now, right?
None of us.
Thank you so much, Ray, for sharing. It's definitely important that we have these conversations with our children. And just like I said, your child is now an adult, so you've learned, right? Because now he's trying to teach you also as you go along. This is what I'm doing. This is what they told me, but this is what my mama taught me. So
all of the above.
Yes, it builds that whole person. You would like to share, Renee?
Oh no, I was just amening every single thing she said.
Okay.
Yeah,
and
definitely,
Shauna?
I definitely use a lot of distraction techniques.
Nice. And what are some of the techniques you use for distraction?
I always do my devotional first thing in the morning because that's when I wake up in the most pain. Like now it's transitioning into fall. So I remember that we have a thermostat that I set it at 7 o'clock, then it comes on the heat. So I don't get up, so I get up in a warm environment. And after I do my devotional, I hit the tea right away. So it's like heater, tea, devotional, all in like the first 40 seconds of getting up, I hit it running.
Yes.
Because as soon as you get up, it's like, oh, that doesn't feel good.
Yeah.
And I try, I suffer from insomnia, but I try to, I set one alarm at night if I know that I had a really bad pain day. So I can take a medicine during the night. So when I wake up, I hopefully can, it's evened out a little bit so I can just do for the breakthrough pain versus to trying to hit it all the way in the morning after, a night when the medicine's worn off. So it's kind of hit and miss because when you're sleeping, you finally get that rest. You don't want to wake up, but it's counterintuitive if you don't, because the pain is even worse. So.
Yes. Thank you so much, Renee, for sharing. That is certainly interesting that you have a routine, and definitely that helps because we know that chronic pain and the acute pain definitely comes when you have your most active and sometimes comes when just unexpectedly. So definitely we're talking about the acute. So definitely you having a routine that helps you is definitely makes some lots of sense,
Especially during seasonal changes. That is the hugest trigger. I would like be looking at my clock like 10, 9, 8, 7, 6, 5, because it's coming.
Yes, it's coming.
Pattern of that. And so being able to recognize that, and that's a whole topic to me, triggers, right?
Yes.
When we talk about pain, we all have to come to the place where we recognize what are the triggers for my situation. Right? Because they're all different. You guys are in Florida and y'all love the heat. I'm in Minnesota where we are cold as you know what. but I literally have a child who hates heat. Like he has to have air and fans. And I'm like, I'm cold. My anemia setting in. Like, can we get some heat up in here? Or when he is in pain, his distraction, like I am not a fan of it. And he's 25, so he's grown, but he want to go ride his skateboard. Sir, are you trying to go to the hospital? How are you? He's like, but that's what gives me relaxation. And I'm like, okay, I guess you circulating all right. But at the same time, know what the balance is, because the body is still the body and has to have proper rest and relaxation, but the mind is still the mind and has to operate in a healthy manner as well. And so getting that mind-body connection for all of us is so important. And then just knowing when those triggers come, don't wait for it to hit you. Know that it's going to come. I love, Renee, that you talked about making sure that you get something in your body on board while you're sleeping, because you don't want to wake up what I call chasing the pain, because chasing the pain is not controlling, is not managing the pain. That's literally just trying to maintain your sanity, right? And so how do we become more proactive so that we are not reactive once the pain is already there and we've done nothing? The other thing that I would say, and particularly with young people, is if you are a young person who wakes up in a lot of pain, tell me a little bit more about how you felt when you went to bed. Did you have a lot on your mind? Did you have a stressful day prior? Do you have something coming up the next day or later in that week that is kind of keeping your body and your mind from being able to rest and presenting a stress to your body? Do you know your body can experience stress even if you're not mentally aware of it? For my son, even any kind of stress triggered him. But what I learned, and I learned this from an older warrior when he was young, stress to the body doesn't know if it's good stress or bad stress. So if he knows he has a big field trip coming up and he's excited about it, his body responds in stress. Because I was like, why is this boy going into crisis every time something he was looking forward to? Oh, his body gets stressed and gets hyped up and gets excited, and then it throws him into a crisis. And so we started having these conversations well before the date so that we could work through even the positive stress, the excitement of it, in order to create kind of more of what they call homeostasis, or an even keel response of the body, so he didn't hyper extend his emotions, which would cause the pain crisis.
Thank you, Ray, for sharing. Definitely.
Shauna, you have your hand up too.
Shauna, would you like to share?
Yes.
Yes.
I love all the ideas. Miss Ray, I think we might be twins when it comes to our kids. Even though my baby's 13, he started having pain really young. The first crisis that he had, he was like, first crisis was 6 months, but we was able to deal with it through the doctor at home. But the second crisis he had, he was 11 months, and it was right before Christmas. And so that's when I started learning that August, I need to start being on pins and needles, because in Georgia, our weather is changing. And so it's cold in the mornings, but in the afternoons, it's super hot. So you start off and it's like, it could be like 40 degrees in the morning. And then in the afternoon by like 2, it's 80. So his body would be trying to figure out, how am I supposed to deal with this? And we noticed one day he was swelling and his face was so big. And I was like, hey, what's going on? He was just screaming. Do you know, like the ER told us, oh, your baby's just crying. And I was so angry because my oldest child is a preemie. So I know how to deal with the hospital when it comes to your children. So I went home, gathered myself, made sure I wasn't acting in my emotions, and I brought him back. And I was like, this is not just crying, it's sickle cell disease. And I feel like this is a crisis. Why else would his face be swelling like this? And I brought my phone and I showed them, this is him on a regular day when he's having fun. This is him today. Something is wrong. And it ended up being an aplastic crisis, and his body has just stopped producing blood cells, and he had to have a blood transfusion. He was so sick, and just so happened T-Boz was at our hospital, and she came by and she talked to me about hydration and things that I could do to help him, and like how it was going to be as he got older, and what I needed to do as a parent to help him. And like the medical team, they kind of left out of the room, and she was just real straightforward with me, like, look, you're going to have to do a lot of work, and this all depends on how you handle this journey, is how he's going to come out. And I took all that to heart. It was like the celebrity went out of the window, and it was like, okay, mama to mama, and this is a mama who has sickle cell. I want to listen to everything she has to say. And his team is so sweet. They didn't want him to spend his first Christmas in the hospital, so they sent us home with a promise that we were to return after the holiday. And just what I learned from that was hydration, hydration, hydration. But later on, I learned what hydration really was. So if any parents is watching, hydration is not juice. Hydration is water.
Thank you, girl. Thank you.
Thank you. Thank you.
Yeah. Like 2 teeth to juice, because I did not know. I was just like, hey, he has sickle cell. Like, oh my God, let's give him everything that I think he wants to have. I can't believe that this is happening to my baby. And for me as a mom, I was a bit traumatized because I had a preemie baby who was in the NICU for 3 months, and then we were always in the hospital. He already knew me in the hospital. So I was like, oh, give you all the gifts. Let me do all the things because I am so sorry. And I am the reason why you have this. So let me just, here, you can have this bear, you can have these clothes, you can have this juice, you can have this Gatorade, you can have all this stuff. And I had to regroup and come back to my senses and be like, okay, this is serious. It is not going anywhere. What can I do to help my baby? And I started with the triggers. Okay, it's cold out. I bought, we were on the bus. So I bought heating blankets, and I would heat
Mhm.
the blanket up before we would leave out so that when we're standing out in the cold, because and I only took them out for sickle cell appointments. And I would heat the blanket up and wrap him up and just try to do everything I could. I would take my jacket off and wrap him up because I
Mhm.
would like for parents to know that there are things that you can see that that child may not tell you. I learned all my kids nonverbal cues. So he has this look in his face when sickle cell is overcoming him, and I know, get the Motrin. But I also want to caution the parents that learn about the medications because Motrin tore my baby's stomach up, and now
Mhm.
we see a GI, and now we take Carafate. That's a medication that kind of coats your stomach
Yeah.
because sickle cell, you do need anti-inflammatory medications. We take the Carafate so that now we can take a leave. And for him, if a leave doesn't work, he knows that, okay, it's time for me to go to my stronger medications. But without the Carafate, we wouldn't be able to take the leave because all that stuff led to ulcers. And I don't want to scare anybody, but ulcers, if your GI knows you have sickle cell and they go into that chart and they see that, oh, you've had a really interesting bout with sickle cell, they don't want to put you to sleep to really see the ulcers. So it's just assumed that you have ulcers based off of, we gave you this medication, you're still puking. We gave you this, you're still having, now you have food sensitivities, and there are certain foods that he cannot eat because we were giving Motrin so much when he was a baby. And like he went from taking like Tylenol, and then they were like the Tylenol coating wasn't working. And so at 3 he started oxycodone. And then that's when you start getting to the ER, they don't like for you to be taking that kind of medication. Back then they weren't educated like that. So the with the triggers, if you learn the trigger, I learned my other kid has asthma. So if you learn the triggers, you can prevent as much as you can prevent. And for us, dehydration, make sure that you're hydrated, make sure that you're drinking your water. If you're going into crisis, change that water over to Gatorade and water, and move as much as you can. For my baby, I noticed that now as he gets older, sickle cell changes. Like sickle cell gets older with you. And
I love the
I
way you said that.
Yes,
It
yes.
gets older with you.
Yes,
Yep.
because you think you know it. We would be in the game, like, okay, we got this. Okay, now it's time for you to take your oxycodone. It's time for us to move on. Okay, wait a minute, you're at an 8. Are you at a low 8? Or are you at your high 8? Because for him, he's so used to pain. High 8 to him, he'll go, it's I need to go to the emergency room. And then I have to explain to them he's not going to cry because crying makes him stressed. And the last time he was stressed, he was in here for 11 days, and he remembers that. So he's just going to tell you that he's hurting. He's had therapy, he's had behavioral therapy where they go in with technology and they look and see, like, when you have pain, your blood pressure does this. When you have pain, when this kid has pain, his heart rate does this. And so he understands that. He knows to put himself into this place. For him, he loves Chipotle. So he pretends like he's at Chipotle. He feels the air hit his face. He eats corn. He eats the rice. He just work those things through. And that's how he calms down when sickle cell overwhelms him in a crisis. But when you get to the ER, it's like, oh, he's not crying, so he's not having that much pain.
Right.
So I would say everything you're saying is right. Talk to your babies when they are not having a crisis so that you know. But I would add to that, know those nonverbal cues so that you can be on point to know
Yes.
that, hey, he's not looking like this. Oh, we didn't get up at 8 o'clock today. Guys, I have 6 kids, so I asked them, did your brother sleep all night? Because I'll stay up as long as I can with him, but I'm getting older and it's hard to pull those
I know
overnight.
that's right.
So my kids, we take my kids, my husband is the fun one. So he plays video games with my son, and like they're like, and they play all night, and that's a big distraction for him. But we notice if he doesn't want to play video games, that's very serious. That means that he's having a crisis because he's a game player. Also, I wanted to tell Renee, there on YouTube, there's a chronic pain, there are chronic pain channels where it's on 432 hertz frequencies, and that music is supposed to help with pain. And his behavioral therapist, she taught us that if you listen to that and you have pain, it may help calm you down. It don't cure anything, but it just gets your mind, and it's no words or anything like that, but it opens up your chakras and things like that. And for him, that really works. So if you're into it or you want to give it a try, it's just any 432 hertz music, and they're doing that in the children's hospitals now here in Georgia, but it's mostly that information is given to the kids who are really sick. So, I don't want to take all your time, but I'm so sorry. 13
Thank
years
you.
is a lot.
No, I love everything that you're saying. And you're right. My son is 25 years old, and about a week before a crisis hits, I can look at him and be like, I'm gonna need you to drink a whole lot more water right about now. I see it. And some days I can call it out. I mean, Carla knows, we have been in the same present. I'm like,
Yes, you do see.
no,
You do see a little
no, I
something
see it
little
coming.
different. Yeah.
And you do. That's what caregiving is about, and that's part of the role. And it's not, it's something you develop. So we understand if you're not yet there. We understand that you might not even know what to look for, but it's finding those little things that may not be obvious to the person or to your child, but is obvious to you. Look, we gave birth to these children, so there's a whole lot we pick up on, even if whether they have sickle cell or not. I know when you done something wrong. I know a whole lot more. But with sickle cell, it is important that we start to recognize the different body language. If he writes different, if he walks different, if he blinks different, like I'll be like, let's see what's going on. So those are all intuition. That's a caregiver's intuition as well. So good job, mamas, and good job, warriors. Unmute.
Thank you so much for sharing, Shauna, and also Renee, and definitely Ray. This was such an incredible conversation that was definitely needed, and we learned so much from each other, right? And we'll continue these community conversations. That's definitely necessary, that we shall be able to learn and just getting information, because as Shauna said, there's different stages, right? So we're constantly learning. We're constantly trying to gather information, and the education never stops when it comes to sickle cell. And being that my child have a different experience than your child and Ray's child, we're all learning. And I can tell you, I pull upon the generation of patients that can share their journey and share their stories, because it helps me as a parent. And I'm able to ask questions. One of the things that I wanted to know, I remember, is prior to my son having any pain crisis, well, acute pain crisis, because he had minor pain crisis starting at 6, but acute crisis that take him to the hospital, I was interested to know from patients exactly describe what that feels like, different from your acute, the chronic pain, the progression of chronic pain that start to occur. What does that feel like? And when I heard that, the description of it, I was like, okay, wow, myself as a parent, then what signs should I look for? Even though I got to learn like the triggers, right? What signs should I look for, and what communication should I talk to my child about, especially when they're in school, right? What can you communicate to the teacher? What can you communicate to others when you're not around me? So those important conversations are definitely necessary. I thank you so much. And
Carla, before you transition, are we on a tight timeline here?
We're pretty much good. We're gonna come back to conversations in a few after the video.
Okay, all right. I have something I'd like to share when we come back.
Okay, certainly, definitely. So we are going to transition now, and we are going to watch a presentation video at Medwick USA. 1 second. Mm-hmm.
While she's looking that up, Shauna, I just wanted to say thank you for talking about the YouTube chronic pain channels, because I think that that's a huge resource that we can get out. If you have any of those links, would you mind putting them in the chat box and making sure that it says to everyone?
Okay.
Carla, click outside the box. Did your video come up?
Hold on 1 second. I'm going back to.
So
I'm trying to do my controls.
yep, click outside the box, click outside, click the gray area outside of your slide.
Hold on. Nope, don't want to do that.
Yep, click that gray area. No, just left click it. Okay, so now when you hover back over that link,
Yeah.
oops, you got to get that other menu off. So click outside there again. So there you go. Now hover over that, your link, and then hit your control button, bottom left of your keypad, and then click the link, and it should pop open. The control button. Oops, nope. You did you have control pushed at the same time?
Okay.
Go back out to the gray area.
Oops.
There you go. Hover over it again. And you're gonna hold the control button down. Whoops.
Did it too soon. Hold on.
Yeah.
Okay. It says slide. No.
Nope. Are you holding holding control down as you click?
Yes.
And it's not coming up?
Let me try it again.
It might be because you're not in presentation mode.
Hold on.
In the meantime, Tony and Cynthia, it looks like has joined us. Would you like to introduce yourself?
Thank you. Thank you for joining us.
Hello, everybody.
Hello.
Hello there.
Hello.
Carla's just working on setting a video up. Carla, you can put the link to the video in the chat box as well, and I can pull it up if you'd like.
Okay, great.
Or you can send it to me privately and I can pull it up.
Yeah, I will put it in the links. We're just working through some technical issues.
Take your time.
Why didn't I? Okay, let me do this. Hold on one second.
All right.
All right, so here is what I have to do. Okay, I just sent it to you, Ray.
All right, perfect. And then would you please allow me to be host?
Yep.
All right. Okay, I'm going to do a share screen. Did you give me that? Perfect. Are you all able to see that my screen?
For a long period of pain. If it's gone on,
I can hear you.
Okay, Tony and Cynthia, would you mind muting?
Okay.
There we go. Okay, can everyone see the screen? Oh,
Yes, yes, we can.
Thank you. Thank you. Okay, I'm gonna hit play now.
Visits, vaccinations, and lifestyle recommendations. But what about treatment and medications? Why, when, and how should your child be treated? Sickle cell anemia can lead to painful symptoms and serious health complications affecting all of the major organs of your child's body. Not only do these lower your child's quality of life, they also reduce their life expectancy. When bone marrow transplant, the only potential cure for sickle cell anemia, is not available to sickle cell anemia patients, treatment is aimed at relieving symptoms as well as preventing painful episodes and complications that may arise further down the road.
Yikes. Sorry, guys. It's buffering.
may feel you want to wait.
Carla, maybe we should put the link in the chat for everyone, and then they can visit it at their convenience.
Until a painful episode occurs before giving your child medication. But managing sickle cell disease is as much about preventing painful episodes and complications as it is about relieving symptoms. Why wait for something bad to happen when you can do something now? Overall, experts believe there's no reason to wait when it comes to treating sickle cell disease. Regular doctor checkups can begin as soon as your child is diagnosed. To help prevent infections that may arise because of sickle cell anemia, antibiotics may be prescribed to babies as young as 2 months old. Also, the U.S. Food and Drug Administration has approved various prescription products currently indicated to treat children with sickle cell anemia. Mom and dad, please ask your doctor about these treatment options. Ask which one will help your child to live better and longer. These should be your top 2 criteria when picking the right treatment for your child.
All right, sorry about those technical difficulties. And back to you, Carla, but you're on mute.
Thank you so much, Ray, for helping with that. I greatly appreciate it. I want to take the time to just thank our guest speakers for coming on. We have Cynthia and Tony Baltmeskis. I am going to read a little bit about Cynthia and also tell you about Tony. Cynthia Baltmeskis was born in Brooklyn, New York, and then moved to Lawrence, South Carolina when she was 12 years old. She was the last child of 15 children. She moved from South Carolina after becoming a military spouse and traveled all over the world for many years. Cynthia is the mother of 2 adult children and a proud grandmother. Cynthia graduated from Excelsior College in Albany, New York, with a degree in liberal arts and currently working on her bachelor's. Cynthia was born with sickle cell SS. She is a sickle cell warrior that has been through health challenges and frequent hospitalizations. Despite sickle cell, she has a great outlook on life. She celebrated her 62nd birthday. Cynthia has not allowed sickle cell disease to define her. She defines herself as a child of God and a woman of victory. Cynthia is an active member of her church. She consistently stays involved in community activities. She started an entrepreneurship business as a certified notary. She also worked as a substitute teacher for many years and also developed her own dance group within church and also at the school she worked at. She's a compassionate sickle cell advocate and a warrior to be determined by so much excellence. So thank you, Cynthia, for joining us today. And we also have her spouse, Tony Baltmeskis. He is a retired Army vet of 22 years. He also retired from the post office, working for 20 years. He and Cynthia has been married for coming 21 years come this New Year's Eve. He has been dedicated to sharing his impactful journey of being a vet and knowing the resources that veterans need. And he is a very, very good resource for us today. So we have joined this couple to come on and just educate us what they've learned from their journey. Thank you, Cynthia and Tony, for joining us. And this part of our session is called Living Beyond the Pain, Life while considering treatment options. So Cynthia, thank you for joining us. Can you tell us about a little bit, I mean, the last of 15 children, like we have a lot to learn now. Can you tell us about your support growing up with sickle cell, and just a little bit about the sibling life, so we can just get an overall view of just a little insight of how your home was and the support network you had.
Hi everyone, that was awesome. I like that. Carla, you did that, girl. However, I am the last of 15 children. I was born in Brooklyn, Kings County Hospital. I was diagnosed with sickle cell at age 3 up there in Brooklyn. And it was very, very hard growing up as a little girl. I remember being in the hospital every holiday, Easter, Christmas, every holiday there was. I don't remember being at home that much in New York. The weather was too much to handle. Blizzards in New York is not good for a sickle cell patient. And as you heard, age 12, my parents moved back to South Carolina, which was a culture shock for me, but a little bit better when it came to the weather. I still was hospitalized because I did not know how to take care of myself. I didn't have a strategy at the time. During my teenage years or my young adult years of, knowing how to keep my blood levels up and to have a goal to stay out of the hospital. I leaned on the pharmaceutical world because that's all I knew. I didn't know any better. It's 3 girls that had the full-blown disease in the family. There's 10 girls and 5 boys. It's only 6 of us left now. Our parents is gone and most of our siblings. There are 2 sickle cell warriors that's still here. I have a sister in Brooklyn that's Linda turned 71 this year in July. She's still doing not as good as I am because she don't listen as well as I do. She don't use the strategies that, I could try to provide for her or we could talk about it. No, she have her way of doing things. I have my way of doing things. And, when they're older, they don't like to listen to the little ones, they think they have the answers. So, but I'm glad that she's still here and I like to spend time with Linda. The last time I seen her was in 2019. She was having a hard time up there in New York with a crisis, and I flew up and spent some time with her. And it was sad to me, because I felt like things was out of my hands. And now that the pandemic is here, we talk on the phone, but her struggle is still her struggle, and ours is totally different. I don't call mine a struggle now. I call it victorious because of God. I mean, listen, we can't do anything without him. I can't anyway. No. So, we just rely on the Lord, and I have a strategy that helps me keep my blood levels up. And I share it with other sickle cell warriors, and some of them, everybody have their own niche. You just have to find your niche. So here we go. Next question.
Thank you, Cynthia. Growing up, were you always aware and having conversations with your parents? Because did they always know you and your other siblings had sickle cell?
Yes. But my parents was born in 1913, 1915. So the lack of knowledge was really there when it came to knowing what to do and knowing how to do it. So they strictly depended on the doctors and their advice. My mom, she's very religious growing up, very, you know, with like holiness Pentecostal. So therefore, her religion beliefs, you know, she raised up her children in the best that she could. However, it wasn't good for a sickle cell patient because in that type of religion, you wear dresses all the time. You know what I'm saying? So being in New York and you wearing dresses, yes, you have on the coat, yes, you have on the tights or whatever, but it was excruciating. Having paying crises with your parents not really knowing or having their own beliefs. You know what I'm saying? You understand? Because in actuality, we did not find out what they had to cause us to be a whole sickle cell patient. So in the early, like, it must have been 1979, 1980, my mom did in South Carolina take me to a sickle cell clinic in Columbia, South Carolina. And I remember my doctor very well, Dr. Milner. He was great. He was very knowledgeable of the disease. So he took it upon himself to come to our home, to test my parents, to see what type of sickle cell that they had. And come to find out, they both had the trait. So that's what made me and my sisters a whole. But we didn't find out till way, you know, later. So at that time, in South Carolina, that's when I believe my early 20s, because now take it, sickle cell, it took the childhood away, it took my teenage years away. So at the beginning of my like 19 and 20, I began to sow my wild oats in South Carolina, if you understand what I'm saying. South Carolina is when she allowed me to wear pants at age 13. In South Carolina, I began to change into my own person. So fast forward a little bit, on up into the middle 20s, like the end, I began to catch my mind. I got rid of the wild stuff, you know, because I didn't have a chance to be a teenager. So therefore, I need to try life out a little bit. So I was I believe at age 27, 28 is when I start settling down, and I wanted to be married. I wanted to be married. I wanted to have children. I wanted to be complete. You know, that's what sickle cell warriors do. They want to be complete. They want to be normal, just like everybody else. So therefore, I believe in 1988 was my first marriage. And that's when I had my 2 children with my first husband. And my children have the trait. Thank God they don't have the disease. Now, as far as my children, you cannot tell Tony these are not his kids. Okay? All right, so next question.
Yeah. Okay. Thank you for sharing that, Cynthia. And we're glad to have you and Tony here. There's a little bit of feedback that I'm hearing. I don't know if you hear it also. I don't know if you have a fan or something that's close by.
Oh, no.
Is it an area? Maybe it's just the area. It's just a little bit of feedback and making it hard to hear.
You know, Cynthia, I love one of the things that you said, because really what you spoke to is the reality of individuals living with sickle cell who want to experience life, right? In our previous segment, we talked about health-related quality of life, but what you're talking about is really social quality of life, right? And those are two different things, and frankly, they're measured differently. And your medical doctors are telling you, don't do this, don't do that, these things are, bad, and yet socially, you're craving, where do I fit in? How do I experience life? How do I feel like there's a reason for me to be here? I can't live in pain and not have a life. That is incongruent. And so, even though other people may have considered some of your activities during that time high risk behaviors, me having a son that's 25, one of the things that I've had to learn, and I have intentionally forced myself to learn, is you are grown. I can share my opinions on what you do, but I also have to recognize that some of your rationales behind what you do is you're trying to normalize your life. You're trying to figure out, how do I enjoy life, the life that's been given to me, without letting this disease define me and all the things I can't do. And I want to prove them wrong because I can do them, right? Because there was a lot of things that as my son's only 25 in comparison to your age. And even then they were telling him all the things he couldn't do. So I can only imagine in your generation with sickle cell disease, all the things you were kind of put in a bubble almost. And so I appreciate you sharing that. I think it's an important thing for caregivers to hear and to understand. My favorite line to my son, especially if I don't agree with what he's doing, I just say, let me know how that works out for you. Because
I've heard you say that.
You grown. Let me know. Or I would get that call. I'm gonna tell you, I had a gala to go to the other night ago. It was a night he has been taking, he had been struggling with pain for the last 2 days. He wanted to go skateboarding. And I was like, listen, don't call me during my gala, because now you are in a 10 out of 10 pain. But I also recognize that the goal wasn't to say, don't go. It was, if this is what you would like to do and this is meaningful to you, just know, make sure you got your meds on board, and balance it so that you are still living a life that's meaningful to you. And frankly, I had to come to terms with the fact that he might do something that triggers his sickle cell, but he might lay in bed in pain with a smile in the back of his head that was like, but I did it. Right? But I did it. So I appreciate that perspective. And with a son that is an emerging adult and figuring out who he is in this life, being able to embrace that and embrace what is quality of life to him. Because what's quality of life is to me is never going to match up, or at least not right now, is not matching up with what his idea of quality of life is. And I have to accept that, because I don't want that difference to get in the way of our relationship.
Yes. Thank you so much, Ray. You gave some great inspirational points also, Cynthia, when you spoke about your household and the doctor that you guys didn't know your diagnosis till a long time out. And the doctor that came actually had the compassion to actually come to your home and test all of your parents and all of your siblings in order to find out. And I think that speaks a lot about where healthcare have been evolving to the interest in sickle cell and making sure, first thing, get the diagnosis, right? Because you had been in emergency room or a sibling had been in that prompted this doctor that was caring that said, make it easier for the household. I'll come to you because you have 15, a household of 15 children. I'm going to come to you and we will test the household. Now that speaks life to itself. And I'm thank you for sharing that. Also, one point that you made was when you got older, you kind of had to explore, right? Explore life. And sharing that is so important, because I think myself, even as a parent of a teenager, now emerging adult, right? He is an adult, but emerging young adult going into, soon will be 20, Lord help him, next year. and me having to understand that he has to explore life because this is how he's going to learn. Can you tell us a little bit about you and Tony? And Tony, I want to hear from you. Now you have met this beautiful, fine woman and learned that she has sickle cell disease. What was important for you and helped you learn more about the disease to better help her quality of life, but also help you understand your role as a caregiver? What helped you?
Well, what it was, when me and Cynthia first met, she was straight up and she told me she had a blood disorder. And then, a couple weeks later, she told me exactly what it was. So I was by myself, so I get on my computer at night and read and found sickle cell and started doing research on it and everything. And then from there, when we did finally get together as husband and wife and stuff, I knew, no expert, but I knew quite a bit of stuff and some signs that I should watch, see if she's overdoing herself that caused a crisis and everything. And I just stepped up to the plate, take care of her, and I noticed some signs and everything. A lot of times she get upset when I tell her, hey babe, you need to slow down because you're overdoing yourself and everything. And then we just talk it and work it out and everything. And then we keep going to different things. And then if she did get sick, one thing is really fortunate, we really have a good primary doctor that we've had for 20 years. She's very good, and she even has done a lot of research on it.
And she prays for us. She prays for me. When I'm sick and I go in the office and I got pain, she literally take my hands and she pray. Where do you find that at? That's rare.
And then too, I was very fortunate when I was working in the post office. I had one supervisor that had a daughter that had sickle cell. So if I needed to take off because Cynthia's having problems, there's no problem with it. And he'd stand up to the main boss for me and everything. Then I had another boss, had a nephew, not a nephew, but a grandson that had sickle cell. And he would stand up for me too and all that and help. They all helped me get into the FMLA. So the post office people, supervise, higher than my supervisors and stuff, couldn't mess with me because I was covered legally then. And I'd even tell them, like one time, Cynthia, I had just started with the post office, and Cynthia called me, and I think you and Miss Carla was working together at the time, and I was delivering mail. And I just went right back to the station, threw my keys to my main boss, and said, hey, I got to leave. Because the wife was sick and everything. He stood right behind me, and I went back to work about 4 or 5 days later. And didn't have no hassling, but if I did, I could have cared less because my main thing is taking care of me.
Thank you so much, Tony, for sharing that. You basically gave us a rundown of some important points. So one thing that helped you was Cynthia just being upfront, just telling you about sickle cell, and then educating you, and then having a supportive physician on board that was able to not only speak with you, that made you feel comfortable, Cynthia, as a patient, but also Tony as a caregiver, seeing the level of care that she was getting. And I think that means so much, even when I'm thinking about myself having a spouse and the kind of spouse that I want for my child, one that's going to be understanding, one that will be open to be educated, and then one that will communicate with the doctor, because this is what I'm doing, right? These are the things that I'm doing. So yes, Tony, I really appreciate you sharing that. And then you spoke about having that support at your job, being able to have someone to understand, my wife has a condition, and having to talk and tell them, not only sharing that information, but having them to be understanding, to know when I need to take off, go ahead. You need to take care of, your wife without having a problem. Because we hear sometimes there's resistance, especially when there's a level of care that warriors need, that maybe need constant medical care. And so it's definitely important. And one thing you mentioned at one point, you said when you first started, from when you were protected. So having that FMLA in place, right? Putting the paperwork in place. So when you need to take off to care for Cynthia, that is so important to have the paper. So you have that job, being able to make those accommodations, understanding that you'll be able, there might be immediate times that you need to take off where it's not going to, you don't have to touch into your sick. But this is first your FMLA time that needs to be understood, that is taken. So thank you so much for sharing that, Cynthia and Tony. I greatly appreciate that. Another thing that you had mentioned, which was really awesome, was also the inclusion of the children, right? The children, letting them know, because at some point too, they also are the caregivers. So they also are the caregivers. So Tony and I'll give Tony a chance, and Cynthia, how do you share speaking with the children when Cynthia is ill, or kind of have they been used to it when she was in the home? What's going to happen next? Understanding mom will be in the hospital, or mom has some medical appointments that she needs to attend to. Do you make it like a family unit when you have these conversations, or do they go to, were they going to appointments? How did you manage that? I'll start with you, Cynthia.
At the beginning, I really wasn't too good at expressing myself when it came to sickle cell. I didn't want to burden my family, or especially my children. So I, up until till we moved to Florida, they was like age 10 or 11. I really kind of laid it out on the line then about it, and the hospitalizations. Because there was one hospitalization, and you were in my life at that time, 2000, 2001. I caught pneumonia real bad. And so I had to be hospitalized for almost 2 weeks. And so I knew that they were going to be missing me. I was going to be missing them. And Tony had to bring them to the hospital to see me. I was in pretty bad shape. So when that episode happened, I had to make it clear to them what to expect, what type of medication I'm on. If I needed them, I would need this type of medicine, or some water, or this, that, and the other. And they were more than willing, because, kids love their mom.
Yes.
So, they handle it pretty good. And I did tell them, I had to tell them about it earlier, because they have a trait. So I did tell them about it. But I tried not to burden them with it. So, and I'm kind of like that now. But now I'm so much better. Whereas my daughter is a naturalist, and she's into aromatherapy and those oils and stuff like that. So now at this point in our lives, she is like, she's almost like a mother hen.
Yes.
She wants me here. She wants her mom. She wants me well. So she's mom this, mom that. Take it easy, mom. Do you have to go there and stuff like that? So, and when I'm not feeling well, she comes with her little, you know, uh, aromatherapy all stuff, and she rubs me down, and she's just, My son, on the other hand, as you know, Carla, is quiet type of person. He don't make a hoorah about a lot of things. He's too calm and collected. So, and he's very compassionate. He's a very compassionate young man. Very compassionate young man. So he holds things in, and he'll cry. My son will cry faster than my daughter. My daughter is the hard nose, and my son is the one that has all the compassion. So they both have been with me to the emergency room where I couldn't drive myself. And so they would take charge and they would let the doctor know what I need, what I'm on. They would help me with the admission, whatever I need. They would stay there for hours with me and be there on a daily basis if I needed them, or if I didn't need them, they still coming in my room. So it's a family affair at this point. It is a family affair.
Thank you. Ray, do you have a question before I go on to my next one?
Yes, I do. And you know, I love to ask difficult questions. Not really difficult, but sometimes the ones that we don't talk about as much. And I apologize, I stepped out to go to the restroom. So if I ask a question that's already been asked, please just let me know. But what I want to know is I want to get down to the emotions of a caregiver spouse, right? Were there moments throughout your journey that felt overwhelming? Like, can I even do this? Can I do this? Why am I here? What do I don't know how to make a difference? Or did you feel like sometimes inadequate as a caregiver to be in that position of providing that level of support? And then how did you maintain your own mental and emotional health through those times, seeing someone you love, not just as a parent, but as a partner, someone that, you know, you are intimately connected to, and not being able to rescue, and just, can you talk a little bit more about what that's like?
Yes, well, one, when I met Cynthia and we decided to get married and stuff, I decided that she came first and everything after the Almighty and all that. And by her going through a lot of problems and stuff through military experience and all that, I knew how to deal with things and all that. And then also like she got sick and had to go to the hospital, you know, from the research and a lot of stuff I learned from her primary doctor, which was Dr. Wong and all that. And I go in there, and if she was in an emergency room, and I'd ask the doctor some questions, and they said, "Oh no, we ain't going to be doing this. We're not going to do that. She just needs a blood transfusion." And then, you know, pardon expression, Dr. BJ is I just use the expression of blood doctor and everything. As even told her, "You don't take no transfusions until I tell you you need a transfusion," and all that. And I had no problem. I had bumped heads several times with emergency room doctors and all that because they wanted to do this and all that. And I tell them, no, she's not going to do this, that, and everything. And then also that sometimes they say, well, we're not going to do this. And I tell them, well, you're the expert, but I know my wife and the stuff that she needs being stuff being taken care of. And if you can't do it, I'm giving you 10 minutes. If not, you need somebody in here to take this stuff out of her arms and all that, and I'll take it to some place that they will listen to me. And one hospital, I bumped heads with them several times, and the other one, they would treat, you know, as soon as I walked in with Cynthia, because the nurses knew her throughout the years and stuff, you know, the whole emergency room would be setting with people, and they just go get a wheelchair and come get Cynthia to take care of it, because a lot of people don't understand when you have a sickle cell crisis, it's just like a person having a heart attack. You don't just leave them sit out there and die sitting in the chair and everything. So, you know, the one hospital, the nurses really know what it's all about, and since they know what Cynthia goes through, you know, it's a priority, which is supposed to be, not just, okay, go have a seat until we get to you and all that. And then, like the one time Cynthia was talking about, she was in the hospital with pneumonia and everything. That year, Chad and Joy, our children, was 9 and 11, and nurses and stuff, you know, because after I got off work, I come home and get cleaned up and get the kids and take them with them to go see the mama and everything. And then they was off because it was Christmas holidays and everything. And the nurse even said, well, if you guys want to stay on Christmas Eve, we'll bring in another thing where the little ones can sleep in it, and we'll get you one too, or you can use it, you know, recliner. So I chose the recliner, and they let, you know, the whole family just stay in the room that night for Christmas.
Wow.
That's beautiful.
Wow.
That's amazing. That's compassionate care.
Yes.
You know, we have a number of adults living with sickle cell disease who have children who do not seek care because they are not being embraced on that level. And so to hear you reflect that story to us is so encouraging, because it is possible, right? It's never what they can't do, it's what they won't do. And so I love the fact that they recognize how important that was. That, I mean, it was a holiday, right? And so though that may not have been a regular practice, this calls for an exception, and they made it happen. And I'll bet, I mean, I don't have any data to say it, but I'll bet that that contributed to a better recovery, because you were able to experience love, care, concern, and that's one less worry you had what was going on with your children when you weren't there. Because we know fathers, we know y'all's good fathers, but we know y'all ain't mamas. So we feel like, oh no, you know. So I love that you guys are team players in this, and that is just such an encouragement to me. And it's encouragement. I saw that Shauna wrote in the chat box that she hopes that her son finds a spouse the way that you have, Cynthia. And I think that all of us mamas really hope that our children can find a spouse who is as compassionate, caring, loving, and seeks to understand on the same level that as a caregiving partner, as their caregiving parent. So that's incredible. Thank you.
You're very welcome. And then too, one other time when Cynthia's getting ready, she's having a crisis now that, and I was taking care of her. And Joy, her daughter, you know, she's like Cynthia said, she's like a kin, overseeing and all that. So I said, well, Joy, I got this all under control. She goes, no, you need to get a hold of Miss St. Clair. She'll help you. And I told her, I got it all under control. And me and her had to get into a big argument in the living room because she wanted Miss St. Clair to take care of our health worker, because she came right out, you know, because she was upset, said, you don't know what to do.
That's our struggle. We working on that though. We're working on it.
I love it. I love it. I love it. Thank you so much for sharing, Tony. That was really a great story for us to actually hear for your journey and being in the hospital around Christmas.
Yes.
And them allowing for the whole family to stay. And we can think of numerous times when warriors are just impacted by losing out on family time, family occasions, birthday celebrations. I know that we celebrated birthdays in the hospital, and unfortunately, this is the life with sickle cell. So when you mention such a compassionate healthcare team that considered that they're here, the best thing for us to do is make a decision. I've never seen the whole family them to stay. That is awesome. And we're talking about adult care. We're not talking about pediatrics, where sometimes they may make some accommodations and say, let's see if, you know, we can have Ronald McDonald House or have one family member stay. But this is beyond pediatrics, adult care, the level of compassion that our adults need in order to get the best care possible. And then mentally, I can imagine how great you felt, Cynthia, for your whole family to be there, and then having a doctor that was listening to what you're considering your family to stay, and your mental health. That was your mental health also being addressed at the time of your physical health being addressed. Yes. So that was awesome to share. And definitely we want to see more of this. We want to see more accommodations, even if they can't let, you know, the entire family let's see what we can do for the entire family so they can celebrate, have a time of celebrating together. So I want to thank each and every one of you actually for joining today. This has been a great session for myself, as well as I know for you all. I thank you for joining the Empowered Caregivers session. We are wrapping up to close at this time. I am going to share my screen because we have one more trivia.
Also, as a caregiver, you know, if it's the man or woman, whichever one is taking care of the spouse and all that, they don't need to be scared to stand up for them. Because one time when Cynthia went to the hospital, I told her who her primary doctor was, because Dr. Wong wasn't doing stuff in the hospital no more, but her boss was, and he overseen Cynthia too a lot. And I stopped on the way home as soon as I found out she was in the hospital, and they had some hospital doctor and had all kinds of stuff listed about this is what's going to be done, this is going to be done. So I went to the head nurse and told him, we already told you this is her doctor. Well, we assigned a hospital doctor to her. And I said, no, you got a little bit of time. You need to get a hold of the doctor you assigned and tell him that our other doctor's taking over. Well, he's not on call this weekend. I said, well, if he has a patient, you should be able to get a hold of him. And I said, I'm going home and get cleaned up. By the time I get back here, we better have our regular doctor in, assigned to her and everything. And they contested, but then they got a hold of me when they were getting ready to head back to the hospital and everything. Said, okay, the regular doctor's assigned to it. And then when I first got there, you know, they changed everything on the board that did show the primary doctor that she's supposed to have anyway. And everything was changed from the hospital doctor, what's supposed to have been done. And then it was Dr. Hartman that Dr. Wong worked for, came in that Saturday morning to check on Cynthia and all that. Said, yeah, and I heard somebody that you was raising Cain about this hospital doctor. And Cynthia just spoke up, said, no, it was Tony that did that. And he just started smiling. You know, he couldn't say anything because he's part of that hospital too, but he just started smiling and took care of Cynthia. And changed
that's what advocacy is all about. And I love that they respected your voice, and that they responded to your voice, and that you had a doctor who responded to the need of his patient. So kudos to you, kudos to that team. It sounds like you have a wonderful care team that you've developed, and it didn't happen overnight. It took years to develop that into something that's comfortable now for you all, that you feel that confidence in. And it doesn't mean you may not still have feedback for them, but they're willing to lean in and listen. So thank you for sharing that.
Thank you so much. We are going into our trivia question. What does the MRI and MRA stand for, and what is it? So we'll give you time. You can.
Shauna has answered the question.
Okay. Okay, Shauna, go ahead.
Shauna, come off of mute and read your answer.
Okay, MRI is magnetic resonance imaging, and MRA is magnetic resonance angiography.
Excellent, excellent. And I did see your note earlier, because you are a vegan and you'd like to share your first prize with Renee. And so Carla, just making sure you got that. And so this, yes, I know. So this prize, I'll let Carla tell you about.
Yes. So this next prize is actually a gift card to Panera Bread. So we have a $25 gift card for you for Panera Bread, and we are excited. Actually, it's two $15 cards, so you can also take your son with you. So it's a $30 gift card. So Panera Bread does have some interesting foods, because my daughter is also vegan. So we hope that you get to enjoy that gift. And now we thank our guests once again Tony and Cynthia for joining our discussion on living beyond the pain, life while considering treatment options. We are so thankful for you joining us today. It was very insightful for us, and I appreciate this conversation, and we appreciate our joining guests, which was Renee and Shauna. Thank you so much. And we will continue our series for 2022, and we will be providing some dates for that, so look out for that. Also, I wanted to definitely take the time to thank our partners for their overall support. We have Mednick USA, Bluebird Bio, which was our gold sponsor, silver sponsor, GBT, Pharma Therapeutics, our bronze sponsor, Trumo, Blood and Cell Technologies, and our supporter, which was Novartis. We thank you so much for your time. As we wrap up, we are going to close with affirmations. With the Power Caregivers session, this is our contact information. You can contact Ray at sicklecellmn@gmail.com, and you can also contact myself at admin@kidsconqueringsicklecelldisease.org. And we thank you so much for our partners and caregivers joining and our patients. We thank you. So we're going to close with affirmations. You can take your the mic off of mute, and you can repeat after me. I am victorious.
I am victorious.
I am victorious.
I will celebrate myself.
I will celebrate myself.
I will be able to accomplish dreams and goals.
I will be
able to accomplish dreams and goals.
I have seeds of greatness in me.
I have seeds
of greatness in me.
I have royalty in my veins.
I have royalty in my veins.
I live with expectancy of great things.
I live with expectancy of great things.
I will prioritize my health and mental well-being.
I will prioritize my health and mental well-being.
I'm going to supersize my dream.
I'm going to supersize my dream.
I can do more than I can imagine.
I can do more than I can imagine.
I am destined to leave a mark on this generation.
I am destined
to leave a mark on this
generation.
I am victorious.
I am victorious.
I am favored.
I am favored.
I am favored.
I am healthy.
I am healthy.
I am well able.
I am well able.
I am victorious.
I am victorious.
Just know that today we are so thankful for you joining us today. Know that keep these affirmations in your atmosphere so you know that you are victorious. You can accomplish all things. You will prioritize yourself. You will live out your dreams and accomplish them. So today we know as we leave this session today, we are victorious.
Right.
Caregivers, we're victorious patients here today. So thank you so much for joining us. I appreciate each and every one of you. Cynthia and Tony, I will share your email as those that would like to contact you and just be in touch with you, because we believe in a network of support where you can always schedule a time where they can ask questions. We know that we need a community of support when it comes to sickle cell, and we keep putting tools in our toolbox. And that's what's helping us. So we thank you so much for joining. I want you to have a blessed day as we leave here today. Keep in mind, you are victorious. Thank you so
everyone.
much.
Have a wonderful weekend. Be blessed. And we appreciate you tuning in. And until next time, be victorious.
Yes.
Don't forget their info. I would definitely want to talk to Cynthia.
Yep. I certainly will. I will certainly be sharing it. I have your info, so I certainly will be sharing that.
Awesome. Thank you
Thank you so much.
You. Thanks, everyone. Bye-bye.
Bye.
See, how do I? There we go.